Okay, so welcome everyone to the 51st lecture of Dr. Haider Step 1. Um, First of all, before we begin, let me check if you guys can hear my voice. If you guys can hear my voice, can I get a yes on the chat box, please? Okay, very well. Okay, how are you guys? I hope you guys are doing well. How was your weekend? Did you guys have a good weekend? It was okay. Yep, it was okay for us too. Okay, very well. Did you guys have a chance to solve some UWorld questions? Did you guys get the chance to solve some UWorld questions? Okay, okay. Before the rest of the students come, the couple of us who are here already, instead of wasting time, can we begin with the revision and recapitulation of today's lecture? I mean, the lecture for the previous lecture. That's what I mean. Can we start our revision and recapitulation for the previous lecture instead of wasting time, please? Okay. Are we ready to begin the revision and recapitulation from the previous topics? Okay, first question. So we are going to begin the revision and recapitulation from the previous topic. Our first question is, if we have a patient with inhalational injury of the lungs from inhalation of a noxious stimuli, for example, smoke, what do we expect to find on autopsy? What do we expect to find on autopsy of the trachea or bronchus? What do we expect to find? Can we get some fast answers, please? It's a very easy question. That's the only thing you have to remember from inhalational injury. Okay, Dr. Uday, very good. Singed hair and suits. Okay, good. If we have a patient with sarcoidosis, can anyone tell me the associated features that are there with sarcoidosis? The associated features? What are the associated features that are there that is extrapulmonary? Extrapulmonary features of sarcoidosis. Anyone? Anyone? It's a very easy question. Extrapulmonary features of sarcoidosis. Very good. We have Bell's palsy from Dr. Karbasi, uveitis from Dr. Uday, granulomas. And then what else? How about the skin lesion? That is lupus pernio. Very good. Anything else? We also have erythema nodosum. Very good. Rheumatoid arthritis like arthropathy, interstitial fibrosis of the lungs. That's the lungs. Okay. Can we get some participations from the rest of the students too, please? We are doing our revision and recapitulation from the previous topic before we begin with the today's one, while we wait for the rest of the students to come and join. Okay. Um, so far we have discussed the inhalational injury and the extrapulmonary features of sarcoidosis. If you have to diagnose sarcoidosis via the ACE levels and CD4 to CD8 ratio, will they be high or low in the serum? Very good. So high in a patient with sarcoidosis, there will be high CD4 to CD8 ratio and high ACE levels. Okay. What do we expect to find? What do we expect to find? The question goes out to everyone. What do we expect to find on a chest X-ray of sarcoidosis? Chest X-ray of sarcoidosis. Fast answers, please. Can we get some fast answers over here? What do we expect to find on the chest X-ray of sarcoidosis? Bilateral hilar lymph adenopathy or adenopathy. Very good. Dr. Mohammed, Dr. Uday, very good. Then what else? What else? What else do we expect to find on a patient with a CT scan? of sarcoidosis? Can we get some answers from the rest of the students? Dr. Han, Dr. Yosef, Dr. Ala, Dr. Hassan. Can we get some answers from you guys, please? What do we expect to find on CT scan? The rest of the students, reticular opacities. Okay, very good. Okay. Okay. If we have to do FEV1 to FVC ratio, if you have to do FEV1 to FVC ratio, how will you differentiate between obstructive diseases and restrictive diseases? Can we get some fast answers, please? How do you expect to differentiate based on FEV1 to FVC ratio? Okay. Okay, very good. So you have a patient with breathing difficulties. Okay. Can we have this question directed to, okay, can we have this question directed to all the 12 students, whoever can answer first, please? So you have a patient with breathing difficulties, shortness of breath. Now the patient on histology of the sputum, she has shedding of spiral epithelium and eosinophilic hexagonal hexagonal shaped eosinophilic crystals. What is the patient's diagnosis? It's asthma. Very good. Okay. Next one. If you have a patient with recurrent lung infections, and now the patient also has some degree of infertility, okay, what are your two provisional diagnoses? Recurrent lung infections, and the patient also has some degree of infertility. What are the two diseases you'll think of? Number one is carcinoma syndrome by Dr. Sadiq. Very good. Next one is what are the two diseases you will think about of lung infections and infertility together? Cystic fibrosis and bronchiectasis by Dr. Hussain. Very good. Okay, that is exactly what we are looking for. Very good answer. Cystic fibrosis and bronchiectasis. Is anyone kind enough to let me know how you will differentiate clinically between a patient of cystic fibrosis and carcinoma syndrome, cystic fibrosis and primary ciliary dyskinesia? Can anyone clinically differentiate cystic fibrosis and primary ciliary dyskinesia on a clinical finding? Absence of vas deferens is not a clinical finding. Okay, clinically, when you are clinically examining the patient, what will you find? What is the differentiating finding in dextrocardia? Very good. Dextrocardia in primary ciliary dyskinesia. You expect to find dextrocardia in primary ciliary dyskinesia. Okay, very good. Okay, so we have, how many types of emphysema do we have? How many types of emphysema do we have? Two types. Okay, century assigner emphysema is more common in which type of patients? Pan-assigner emphysema is common in which type of patients? Pan-assigner. P for antitrypsin. Century assigner. S for C for century, or we can also spell it like SENTRI, century, and then S for smoking. Okay. Okay, very well. Do we have any new students with us today whose lecture is this the first lecture? Do we have any new students with us? Do we have any absolutely new students with us today? Anyone? Is anyone over here a new student? Please use the chat box to let me know if you're a new student. Okay, Dr. Bashir. Okay, so welcome to our lectures by Dr. Haji Step 1. This is a full text by text breakdown of first aid. Okay, this is a 4 to 5 hour lecture. This lecture is basically divided into 3 to 4 segments. The first segment is based on revision and recapitulation of previous topics. As you know, this is the 51st lecture, meaning that we are studying the respiratory system. We started all the way from cardiovascular system, that is the organ systems, and now we are going to move forward with finishing the respiratory system. As of right now, we are studying respiratory pathology. We are going to begin with pneumoconiosis from today. Okay. After this, we are going to jump into genetics and biochemistry. That is the basic science chapters this week, hopefully from today or tomorrow. And all the lectures which you have missed till now, that is close to almost 50 lectures, what we will do is after we are done with the respiratory system, we will do the basic science portion of first aid. After we are done with the basic science portion of first aid, we will start with all the organ systems once again. We will start with CVS, endocrine, neuro, GI, musculoskeletal, reproductive, everything to all the systems. So basically, this is like a cycle. So when the first cycle ends, the second cycle begins. So when you start the basic sciences, that is another cycle by itself. Okay, so we are going to start the basic sciences from where we will end it all the way to the respiratory system. Having said that, the first segment is the revision, where we are revising the previous topics for the students who are already here. The second segment is where we read first aid, and that's the longest segment of the lecture. The third one is we solve high yield UWorld and embossed notes, which are extremely difficult for most of the students. That is the questions which are in the 30 to 40% mark range, which are answered correctly. And the last segment is we do 5 to 6 UWorld offline or Kaplan offline questions every day. Okay, so having said that, this is how the lectures are going to run. It's a 5 days lecture from Monday to Friday, New York Eastern timing, 9 a.m. to roughly 1:30 to 2 p.m. via Zoom. Do you have any questions for us, Dr. Bashir? Do you have any questions for us? As you are a very new student? Okay, very well, very good. Okay, so let's continue with the revision and recapitulation. We already have most of the students who have joined us. Okay. Okay, so before we begin with the next question, can we just draw this up real quick? I'm going to share up I'm going to share my screen over here. Okay. What we are going to draw is we are going to draw the flow volume loops, and easily, can I get some fast answers over here that if I draw a graph like this and in a flow volume loop, you guys know that this is the flow, this is the volume. Okay, and over here, if we have this sort of a finding, what can you expect the disease the patient this patient is suffering from? What is the disease this patient is suffering from? Can we get some fast answers, please, on the chat box? Very good. Obstructive diseases. Obstructive diseases. Okay, because this would have been the normal finding. Okay, another one, if we have this type of a finding over here, okay, this type of a finding over here, the one with the blue line, what do you guys think this patient is suffering from? Restrictive diseases. Very good. Okay, what are the lung changes in a person who is elderly? In an elderly person, what are the lung changes? What are the lung changes? Increased residual volume, decrease FVC. What happens to the total lung capacity in an elderly individual? Okay. Okay, let me ask you a very high yield question from the UWorld, which has been added recently. I'm not sure if you guys have found it or not. Okay, let's say that this is, okay, this is a new question comparatively. This has been added to UWorld, and UWorld is adding questions every day, which are really new. Okay, so first of all, imagine that this is the chest x-ray of a patient. Okay, and this is the lung marking over here. And this is another lung marking over here. Okay, one second. This is the lung marking over here. Okay, this is another lung marking on this side. Okay, so we have right and left. Okay, and then over here, what we have is we have this sort of a finding on X-ray. Okay, and now my question is, so you have a patient who was an unrestrained driver driving a vehicle. He was an unrestrained driver driving a vehicle. And after that, he got into an injury and he was taken to the hospital, and his blood pressure has been 110 over 60. His pulse is 95. Okay. Respiratory rate is 22. Temperature is 98. Okay, so blood pressure, pulse, temperature, I'm sorry, respiratory rate, and temperature. Okay, now, what do you think this patient is suffering from? This patient also has a chest pain. Every time he or she breathes, there is chest pain. Okay, and so this is basically what the finding is. And the trachea over here, okay, the trachea is centrally positioned, central position of the trachea. The trachea is not deviated to either of the side. Okay, now, this is not a pneumothorax, okay? This is not a pneumothorax or a pericardial effusion. Okay, I'm going to give you guys another second or two, okay, before I jump in and I let you know what's going on with this patient. Okay, we will use some of the knowledge which we have used from before from the CVS, but collapsed lung, nope. If the lung was collapsed, then the trachea would have been deviated. Pneumomediastinum is not the right answer because there is no extra type of finding. The only positive finding which I've tried to show over here is this positive finding. Okay, this is okay. Keep in mind that this whole thing is not the heart. The heart is not this big. Okay, the whole thing is not the heart, but um, there is opacity over here. Okay, this part is comparatively darker. There's an opacity. So this type of opacity, very good, very good. Dr. Jordan, Dr. Hussam. Okay, good. This is an aortic isthmus damage trauma, and this shows that this is a widened wide mediastinum. Wide mediastinum. And this one over here, this finding, this in a normal X-ray, this is an aortic notch. This is an aortic notch. So over here, this prominence of aortic notch, prominent aortic notch, and widening of the mediastinum, these are your two findings for aortic isthmus tear. Aortic isthmus tear. And traumatic mediastinum. Are we clear about this? Are we clear about this finding, everyone? This is very, very high yield. This is a comparatively new question which has been added. Are we clear about this? Okay. You have a student. I remember you mentioned it in UWorld. Oh, I did? Okay. Did I mention this in UWorld notes before? Did I mention this in the UWorld notes before? Uh, okay, so I suppose that this is not a very new question. Then I guess we have done it before. To be honest, we have done so many questions, we barely even remember what is real and what's recent or what's not. Okay, but the chest X-ray says pretty high yield. The chest X-ray is pretty high yield. In a chest X-ray of a patient of aortic isthmus damage, you have two findings. That is a prominence of aortic notch and widening of the mediastinum. Okay, widening of the mediastinum. Having said that, can we ask you guys what are some of the causes of anterior mediastinal masses? Anterior mediastinal masses. All the T's, very good. Thymoma, trauma, teratoma, and Terrible lymphoma. Terrible lymphoma. Okay. 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 Very well. Very good. Okay. So we are going to begin with our lecture, which is pneumoconiosis from today. Okay. Pneumoconiosis. We are going to begin the lecture from over here. Is everyone ready? We are done with the revision and recapitulation, the first segment, and we want to jump into the first aid text. Is everyone ready to begin with pneumoconiosis? A very high yield topic. Yes. Okay. Okay, so we are going to begin with pneumoconiosis over here. What we're going to do is we're going to read the book. Read the page, half a page or a full page, and then we will go back to a blank page, and then we will make sure you guys have understood or not. Okay. So without further ado, let's begin. The topic that we're going to discuss today is pneumoconiosis. Pneumoconiosis is basically occupational lung injury. Okay, so occupational lung injury, meaning lung injury that happens due to certain specific occupations. First of all, we have to talk about the highest yield one, that is asbestosis. Asbestosis over here in the USA nowadays, it's not used to form roofs for insulation anymore, but in the past, asbestos was used for roof insulations in every other houses. So over here right now, if you have a patient who has been who has been affected by lung injury due to asbestos, they can actually file a complaint and get a compensation. Okay, so asbestosis, this is associated with shipbuilding, roofing, and plumbing. This is extremely high yield because you have to understand, because the questions will come accordingly. They will tell you that you have a patient who was a previous who was a previous worker in a ship manufacturing company or a roofing company or a plumbing company. So shipbuilding, roofing, and plumbing. These are the three occupations where someone can get exposed to asbestos. Okay, asbestos. Okay, that's the source. Next one. What do we find in a patient with asbestosis? We find what we find is we find ivory white, calcified, supradiaphragmatic, and pleural plaque. So over here, if you can see, if you can see over here, that you can see the ivory white, calcified, supradiaphragmatic, these pearly things. These pearls, these are known as plaques. These are on top of the diaphragm. So this is a section of a diaphragm on autopsy, and over here you find these type of plaques, the supradiaphragmatic plaques, and these are calcified. And over here you also find this pleural plaques. Pleural plaques, in order to identify them, this is the border, right? And along the border you will see these type of chalky white findings. These are your ivory white pleural plaques on a CT scan. So that's that. Okay, and then the patients, these are the two findings. Okay, so we're done with the two things that you need to know. The second one is what happens if you're exposed to asbestos. What happens is you have a risk of bronchogenic carcinoma, or which is more than the risk of mesothelioma. But the two carcinomas are bronchogenic carcinoma and mesothelioma. These are the two findings. And over here, if you have a patient with pneumoconiosis and the patient also has rheumatoid arthritis, so two diseases at once, this is known as Kaplan syndrome. This is known as Kaplan syndrome, meaning that a patient with rheumatoid arthritis, due to decreased functioning of the immune system, they can also have they can also be co-affected with occupational lung disease such as pneumoconiosis, and this two together is known as Kaplan syndrome. Okay, so next time you hear about Kaplan syndrome, try to think about rheumatoid arthritis and pneumoconiosis. Okay, that's that. Okay, asbestos will always affect the lower lobes. Okay, now if asbestos did not affect the lower lobes, you would have never found supradiaphragmatic findings. This is very easy to understand, meaning that if this is the diaphragm, since asbestos will affect the lower lobes, that's how you find the plaques on top of the diaphragm. Okay, so this is very easy to understand. Both of them are easy, meaning that in asbestos you find supradiaphragmatic plaques, and the reason is you get, and the reason is you have the asbestos, which affects the lower lobes, of the lungs. Okay, so that's that. Okay, next one. Next one is, if you want to find, if you do a histopathology, how do you know that the patient has asbestos? If you do an asbestos study, then you can find in the lungs you have asbestos bodies, which are golden brown, resembling dumbbells. Over here, these are known as asbestos bodies. Okay, these are known as asbestos bodies. They can be found in sputum samples. Okay, so let's say someone gives a sputum for a culture, and then over there for microscopic appearance on the sputum, you can find asbestos body, which are ferruginous bodies, meaning that they're iron containing bodies. If they are iron containing bodies, then the stain which we are using is Prussian blue stain. So that's that. So Prussian blue stain. So these are the things that we have to understand and remember about asbestos. There's also an increased risk of pleural effusion. That's also that. Okay, so basically the two types of carcinomas are malignant mesothelioma and primary bronchogenic carcinoma. That's that. Okay, are we all clear about asbestos? Okay. What are the two diaphragmatic findings of asbestos? Asbestos, is it a supradiaphragmatic or infradiaphragmatic? Supradiaphragmatic or infradiaphragmatic? Supradiaphragmatic. Very good. Okay. Okay. Prussian blue isn't for hemosiderosis too? Yes. Iron containing. If you want to detect iron, then you will do a Prussian blue stain. Next one. Next one is berylliosis. Who are the affected individuals of berylliosis? Okay, the affected individuals of beryllium are patients who have had a history of working in aerospace and manufacturing industry, meaning that, for example, you can have a question over there that you have a patient who used to be a worker in a manufacturer of NASA, okay, of NASA or the rocket ships. I'm not sure if you guys have received this question in New World as of yet, but you will. So a patient who has had a history of manufacturing the rocket ships in NASA, that is a very common question for beryllium. So if you have that type of a patient, please remember that they are directing you to beryllium exposure, that is berylliosis. And what happens is when you have a patient who has been exposed to beryllium, over here, what you find is, let's say that these are the patient's lungs. Okay, what happens if beryllium, they come into the lungs, they stay in the lungs, and in the lungs there are immunological responses. So we have the alveolar macrophages which tries to come and phagocytize the foreign substance, but they can't because they are solid substances which cannot be broken down by the proteases. So what happens is there is chronic inflammation and formation of fibrosis, and then after that what you have is you have a formation of a granuloma, which are non-caseating granulomas. So there is no central necrosis because the central part contains the foreign substance. So you have granulomas over here on histology. And what happens with this one is beryllium will always affect the upper lobes. And the way I try to remember this is, you, okay? Okay, upper lobes. Upper lobes, instead of B's, use P's. B for beryllium, B for upper lobes. Okay, I know it's a bit silly, but it will help you. So lower lobes are asbestosis, upper lobes are beryllium. That's that. Okay, next one. Next one is coal worker's lung. Next one is coal worker's lung. Okay, next one is coal worker's lung or coal workers pneumoconiosis. Who are the patients who gets affected to coal work, to coals? So prolonged dust exposure, what happens is, at the same way how beryllium comes, coal also comes. Coal is basically carbon. So they come and they stay in the lungs, and then there's inflammation and fibrosis, and then there's formation of a granuloma. So that's exactly what's happening over here too. But the thing is, in coal worker's lung, the coal, the carbon is black in color. So what you have is this is the whole lung, they kind of turn black because there's so much deposition of carbon over here that the lung kind of turns black. And this is also known as black lung disease, also known as black lung disease. And over here, you also have a risk of developing Kaplan syndrome, meaning that these patients can also have development of autoimmune rheumatoid arthritis. So rheumatoid arthritis can also develop with exposure to coal, and this is known as Kaplan syndrome. That's them. Okay. And coals over here, coal also affect the upper lobes. Coal also affect the upper lobes, and the way you can try to easily remember is you have your ABCs, right? You have your ABCs. So over here, A is for asbestos. Asbestos was lower lobe. B is for beryllium. B is upper lobe. C is for coal workers. C is also for upper lobe. So upper lobe. These are also there in the upper lobes over there. And this is known as anthracosis. Anthracosis, meaning that coal worker's lung, the word we used to use before was anthracosis. Okay, so that's that. Next one. Next one is silica, meaning that exposed to silicas. Who are the patients who gets exposed to silicas? The patients who are exposed to silicas are patients who has had a history of working in sandblasting, foundries, and mines. Sandblasting, foundries, and mines. Okay. Before we jump into this any further, what I will do is I will help you guys make a table, which I need you guys to write down over then here in this portion of your page. Okay. Use your post-it notes if you have to, or use your notebook if you have to. But let's make a small make a small note so that it's easy for you to revise. So you have your occupational lung disease in one part of the table, and you have the occupations. You have the occupations in over here. First one is asbestos. So the first one is asbestosis. Okay, who are the patients who are exposed to asbestos? The patients have a history of shipbuilding, right? We just learned about this. And then roofing and plumbing. The reason why we're doing this is because if you guys can identify the pneumoconiosis from these words in the question, then 90% of the time the questions will be answered right. Okay, so high yield that you form this table. Asbestos is this one. Then the next one that we studied was beryllium. So ABC. So beryllium is berylliosis. Berylliosis. Who are the patients who are exposed to berylliosis? The patients are who have had a history of working in aerospace and manufacturing industries. Basically, aerospace is more high yield. Okay, manufacturing industry. Okay, next one that we want to talk about was anthracosis, or coal worker's lung, right? Anthracosis, ABCs. Anthracosis. Anthracosis, the patients have had a history of working in coal dust or coal mines. Okay, coal dust or coal mine exposure. Last one that we have discussed is silica. So it's silicosis. Silicosis patients have had a history of working in sandblasting, foundries, and mines, also mines over here. Okay, And over here, asbestos is the only one which affects the lower lobe, and everything else will affect the, wait, 1 second. Okay, 1 second. This is lower lobe, and everything else is upper lobe. Beryllium is from upper lobe, anthracosis is for upper lobe, and silicosis is for upper lobe. If you have these, this small notes over here, if you can write this down on this part, okay, then you can revise the pneumoconiosis in 1 second. Okay, in 1 second, you can revise the pneumoconiosis in 1 second, and these are the highest yield things that you need to answer the questions in UWorld. Okay, are we clear? Are we clear about this? Are we clear about this? Okay. Are we clear about this? Sandblasting and foundries, yes. Sandblasting and foundries. Do you guys know what a foundry is? Foundry. You guys know what a foundry is? This is a foundry. Okay. This is basically a foundry where you cast metals. Okay. Did you guys draw down the table, which I asked you to draw it down? This table? Sandblasting. Sandblasting is also a type of foundry over here. What you have is, okay, this is sandblasting. You blast sands. Okay. Are we clear? Dr. Han, do you have a question? Dr. Han, do you have a question? Okay, very good. Okay, so are we clear about, so can we do a fast revision and recapitulation? Okay, before that, we have not finished silicosis, so let's do that. So silicosis is from sandblasting and foundries. Next one is, once again, if the silica comes and it deposits inside the lungs, the macrophages will try to phagocytose the silica, and that will not happen because they cannot be broken down by the substances. So what they will do is they will form the granulomas, and this can also lead to fibrosis. And what happens is, over here, silica is very high yield for a very important question. Okay, please put your stars for this question. It is thought that silica may disrupt the phagolysosomes and impair macrophages and increase the susceptibility to tuberculosis. So what happens is, in tuberculosis, do you have granulomas in tuberculosis? Yes or no? And what happens when you have a primary TB? In primary TB, you have granulomas which have walled off the infection. There is walling off of infection. And in secondary TB, what you have is you have reactivations. So if this is a primary TB over here, and there's walling of infection by the macrophage, the granuloma, the silica, what they will do is they will come and they will disrupt the wall. They will disrupt the walls of this one. So this will allow the TB to leave and disseminate into the blood and form secondary tuberculosis. And this is known as reactivation. So this is very high yield. The knowledge that silica can cause reactivations of tuberculosis is very high yield. That's that. Along with this, they can also cause carcinoma, core pulmonary, meaning right heart failure due to lung damage, and Kaplan syndrome. Once again, autoimmune rheumatoid arthritis. That's that. Okay, autoimmune rheumatoid arthritis. But silica causing lung damage. So if you have anything which can cause lung damage, lung damage via tuberculosis, then silica is the one. Okay. Another high yield finding over here, what you will find is silicas where they affect the upper lobes. We have already talked about this. Another one is what you have is you have eggshell calcification of hilar lymph nodes. You have eggshell calcification. Let me show this. Okay, eggshell calcifications of hilar lymph node. What you get is you get these type of findings over here. you have, let me show you these type of findings. Okay, looks like a shell of an egg. Looks like the shell of an egg, eggshell calcifications. Okay, bilateral eggshell calcification. Although this is the image for sarcoidosis, okay, where there's bilateral hilar lymph adenopathy. Okay, but you also get eggshell calcifications like this one over here. Okay, are we good with pneumoconiosis? Are we good with pneumoconiosis? Okay. Before we leave, I have to make sure that you guys have understood this, okay? Because we want to make sure that you guys have learned first aid all together during the lecture, because the rest of the day should be spent on doing UWorld questions, okay? The rest of the day should be spent on doing UWorld questions, okay? Okay. First of all, let's ask you the question: asbestos, asbestosis. Who are the patients who will get exposed to asbestos? Can I get some fast answers, please? Who are the patients who will get exposed to asbestos? Fast answers, please. Patients who will get exposed to asbestos, shipbuildings, roofing, and who else? Plumbing. Very good. Asbestos. Which lobe does it affect? Which lobe does asbestos affect? Lower lobes. Very good. Okay. Lower lobes. Okay. Very good. Very good. Very well. Next one is beryllium. Who are the patients who get exposed to beryllium? Patients who get exposed to beryllium. Okay. Okay, very good. Next one is coal workers lung or anthracosis. Who are the patients who get exposed to anthracosis? Okay. Next one is silica. Who are the patients who get exposed to silica? Silica. Okay. If you have a patient who is involved in manufacturing of aeroplanes or planes, what is the pneumoconiosis? Very good. If you have a patient who is a plumber, what is the pneumoconiosis? Very good. If you have a patient who is exposed to sandblasting, what is the pneumoconiosis? Okay. If you have a patient with supradiaphragmatic plaques and pleural plaques, very good. What are the two carcinomas affected by asbestos? Okay. If you have a patient who has no exposure to cigarettes but exposure to asbestos, what is the carcinoma? Only asbestos exposure but no cigarette exposure or smoking exposure. What is the carcinoma? Malignant mesothelioma. Very good. If you have a patient who has had exposure to cigarettes and asbestos, what is the carcinoma? Bronchogenic carcinoma. Asbestos and cigarettes together is primary bronchogenic carcinoma. Okay. If you have a patient with eggshell calcifications of hilar lymph nodes, what is the pneumoconiosis? What is the pneumoconiosis? Silicosis. Okay. Silicosis. Okay. So, how do we feel about pneumoconiosis? Are we confident? How do we feel about pneumoconiosis? Are we confident? Okay, I don't understand the cigarette question. Okay, so if you have a patient who has been exposed to, if you have a patient who has been exposed to cigarettes and asbestos together, the patient will have bronchogenic carcinoma. Only asbestos, the patient will have malignant mesothelioma. Okay, are we clear? Bronchogenic carcinoma with asbestos is more common along with smoking. Okay, having said that, how confident are we with pneumoconiosis? Are we confident with pneumoconiosis? If we receive questions, can we answer them properly? Okay, how about, okay, Dr. Bashir, our new student, are we confident with pneumoconiosis? Have you understood pneumoconiosis? Dr. Han, Dr. Bashir, students, have you guys?
Yes, I'm good.
Okay, very well. Okay. And okay, so if all is well, my question is, if you guys receive questions in UWorld from pneumoconiosis, are you going to be confident or not, knowing that you guys know almost everything about pneumoconiosis from at least from first aid? Everyone, okay, which is the goal of our lecture, is to make you confident, right? So hope you guys will answer everything with confident, and I know each and every one of you will answer the questions correctly each and every time. So that's that. Having said that, let's move forward to the next one, that is mesothelioma. So what is mesothelioma? Mesothelioma is basically malignancy of the pleura associated with asbestos, with asbestosis. What happens is that in mesothelioma, you find that there may be uh, pleural thickening. This is the only thing which you will find over here. So as you can see over here, that you have this pleura, and then there's this area of thickening. Okay, this is by the plaques. As you can see, that the white substance over here, this is the calcified plaques. So there's pleural thickening, and this is very high yield. Okay, and what happens is on mesothelioma, you also find psammoma bodies. You also find psammoma bodies. Does anyone know what a psammoma body is? Does anyone know what a psammoma body is? What is a psammoma body? We have discussed about this so many times in the past. Psammoma body. What is a psammoma body? Anyone? Right. Right. Very good. It's basically a whirled up collection of calcium. If calcium were to get whirled up, okay, by that I mean that if calcium deposition occur in this whirling pattern, right? If this occurred in this whirling pattern, this type of whirlies of calcium is known as psammoma bodies. Okay, so over here on histology, if you do a histology, you can find a psammoma body. And can I show you how a psammoma body looks on histology, since they've failed to mention it? Okay, psammoma bodies on histology, they look like this: calcified. As you can see, that there's this whirled up calcified pattern. This whirling is known as psammoma body. Or if you find psammoma bodies on pleura, then these are very high yield for mesothelioma. And along with this, if you do two types of staining, the stainings are calretinin and cytokeratin. Calretinin and cytokeratin, they are positive. Calretinin and cytokeratin. Okay, these are the two ones. And over here, mesothelioma, smoking is not a risk factor, as I have just told you guys how that smoking is associated only with asbestos. I mean, smoking my apologies, smoking is associated only with bronchogenic carcinoma, and asbestos is only associated with malignant mesothelioma. So this is the only carcinoma of the lungs, or the pleura of the lungs, where smoking is not a risk factor. So that's that. Smoking is not a risk factor. Okay, so that's that. Okay. Are we clear about this? Are we clear about malignant mesothelioma? Are we clear about malignant mesothelioma? Yes or no, guys? Can I get some fast answers? Have I told you guys about my two friends who are in the roofing industries, who had asbestos, and they unfortunately they kind of passed away? Have I mentioned you guys about my two friends? No? Do you guys know the names of my two friends who had asbestos, and unfortunately they kind of passed away? Okay. One's name was Red, another one was Kate. Okay, very good friend of mine's. They were in the asbestos industry. They used to do roofing and plumbings together, and then unfortunately both of them had malignant mesothelioma, and they kind of passed away. They kind of passed away. So that's very unfortunate. But what it did was, red is for red is for calretinine, calretinine, and Kate is for cytokeratin. cytocarotene. Okay, I'm not sure if you guys can. Okay, cytocarotene. Okay, so from over here, calretinine and cytocarotene. So red and cake, two of my friends. Okay, so what are the two stains that are used to stain mesothelioma? Fast answers, please. Fast answers, please. Two stains which are used to stain mesothelioma. Very good. Calretinine and cytocarotene. Are we clear about this? Okay. Okay, can I get everyone to join in on the chat box and please answer me the question so that I realize how confident you guys are? Okay, so that I realize if you guys are confident or not. Okay, calretinine and cytocarotene. Next time when you guys receive questions about positive findings of calretinine and cytocarotene, the disease I want you to think about is malignant mesothelioma. Okay, next one. Next one that we want to go to is acute respiratory distress syndrome. Before we move on to acute respiratory distress syndrome, do you guys have to spend any more time on pneumoconiosis and try to remember what you guys studied or what's important or what's not after doing this part with us? Yes or no? Do you guys have to spend more time on understanding what's important and what's not? If you guys receive questions straight away from UWorld, can you guys or can you not answer the questions perfectly from UWorld? Yes or no? Okay, good. Very good. Okay, next one. Next one is acute respiratory distress syndrome. Okay, I'm pretty sure you guys already know what acute respiratory distress syndrome is. Acute respiratory distress syndrome basically is an insult to alveoli. This is an alveolar insult. What happens is you have a systemic disease, and that systemic disease, this releases a lot of pro-inflammatory cytokines, And what those cytokines does are they causes neutrophil recruitment, that i.e. chemotaxis, activation, and then release of toxic mediators such as proteases and reactive oxygen species. So what that does is this release of proteases and reactive oxygen species, they cause capillary endothelial damage and increases the vessel permeability. What happens when you increase the vessel permeability is that you have leakage of protein-rich fluid, meaning exudation, right? And then this exudation kind of hardens up, right? That's how I like to think about it. That is, if this is a vessel, then you have the leakage of fluid, and over time, the fluid stays over here for a long period of time. The fluid kind of hardens up because they contain a lot of protein, right? And this hardening of the fluid, this protein-rich fluid, is known as hyaline membranes. And this can result in the formation of acute respiratory distress syndrome. Very easy to understand. And also non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema. And another one is if there's also loss of surfactant, then this also contributes to alveolar collapse over here. So once again, if I have to draw it out in a pathway, okay, I know that a lot of students, they prefer the textbook. A lot of students, they prefer the blank pages. So if I have to draw it out on a pathway, what you have is at first you have a systemic disease, right? You have a systemic disease, let's say pancreatitis, very high yield for causing ARDS. They release a lot of pro-inflammatory cytokines. Inflammatory cytokines, they cause neutrophil recruitment, that is chemotaxis, and activation. Neutrophils, what they do is they release proteases, right? They release proteases, and what else? Reactive oxygen species. These things, they cause lung damage, increases the vessel permeability, leakage of protein-rich fluid, that is exudation, and then over there you have formation of hyaline membranes, and all in all you have ARDS, acute respiratory distress syndrome. Okay, now what are the causes of acute respiratory distress syndrome? The causes are, number one is sepsis. Sepsis is very common. After that you have aspiration, pneumonia, trauma, pancreatitis. These are some of the causes of acute respiratory distress syndrome. That is sepsis, aspiration, pneumonia, trauma, and pancreatitis. That's that. Okay. What are the diagnose? How can you diagnose a patient with acute respiratory distress syndrome? The diagnosis is, at first you have an abnormal chest X-ray in which you have bilateral lung opacities, right? So you have bilateral lung opacities. Then what you have is you have respiratory failure within 1 week of alveolar insult. Within 1 week of alveolar insult, you have respiratory failure. And then AR, then D4, decrease in partial pressure of oxygen divided by inspiratory oxygen ratio, which is less than 300. This is sort of high yield, okay? And the thing is, what happens is the ratio decreases over here. The ratio decreases because FiO2, meaning that the inspiratory oxygen, this decreases way more, because what happens is the lungs cannot expand at all. The lungs, they fail to expand at all, because throughout the lungs, what you have is you have this ground glass appearance of the lungs. Throughout the lungs, you have this ground glass appearance, right? So the lungs, they cannot expand. If they cannot expand, they cannot inspire air. If they cannot inspire air, then if you have a ratio like this, okay, if you have a ratio like this, then what happens is FiO2, they decrease, but the partial pressure of oxygen, they decrease 2 times more. Okay, so what happens is this ratio altogether, this ratio decreases less than 300 or whatever, but as a whole, this decreases to less than 300. And what happens is there's also hypoxemia. Why do we have hypoxemia? We're having hypoxemia for the same reasons. That is, we have a decreased inspiration. As a result, decreased oxygen is coming in, and we all know that in the lungs, if we have hypoxia in one region of the lung, then there is vasoconstriction, because the lungs tries to push the blood to an area of well ventilation. So you have intrapulmonary shunting and diffusion abnormalities. That is VQ mismatch. That's that. And along with this, you also have symptoms of respiratory failure, which are not due to heart failure, meaning that you have shortness of breath and maybe some degree of pleuritic chest pain, but the patients do not have increased JVP or peripheral edemas, right? They do not have that, which are signs of heart failure. So they do not have that. Once again, the diagnosis is number 1, abnormal X-ray, that is ground glass appearance of the X-ray. R for respiratory failure, D for decrease in PaO2 by FiO2. Then the last one is symptoms of respiratory failure without symptoms of heart failure. That's that. What are the consequences? The consequences are you have impairance of gaseous exchange. Patients have hypoxia, decreased lung compliance, meaning the lungs cannot stretch, i.e. this thing is happening. And also what you have is pulmonary hypertension. Once again, you have vasoconstrictions in parts of hypoxia of the lungs, so you have pulmonary hypertension. Management. How do you manage a patient with ARDS? Very easy. First of all, you have to address the underlying cause. That is sepsis. If you have sepsis, then treat the sepsis. If you have aspiration, then you have to get rid of the foreign substance which is causing obstruction. So aspiration is that. So get rid of that one. If you have pneumonia, treat pneumonia with antibiotics. If you have trauma, then surgical intervention. If you have pancreatitis, then treat the pancreatitis by antibiotics, nothing per oral, and all the other things we use to treat pancreatitis. We do that. And eventually, the ARDS will resolve. If it does not resolve, what do we do? What we do is we do mechanical ventilation. Mechanical ventilation basically meaning that with the help of a machine, we try to make the lungs ventilate. So mechanical ventilation, which is basically increase in PEEP. PEEP is basically positive end expiratory pressure, positive airway pressure. And this is increased and the tidal volume is decreased. We decrease the tidal volume over there. Okay. And with these two pictures, the first one is showing the hyaline membranes, as you can see over here, that these membranes over here of the lungs are the hyaline membranes. And this is showing the ground glass opacity of the lungs. Okay. Are we clear about this? Please, the pathophysiology again. Okay. Pathophysiology of ARDS. Okay. Does anyone have any other question? Does anyone have any other question? Okay, FiO2. Anything else? Anything else? Any other question? Okay. So one by one. Okay. So one by one, let's break down ARDS. Once again, I'll break down ARDS. Okay. 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 First of all, ARDS is acute respiratory distress syndrome. What is the pathophysiology of ARDS? The pathophysiology of ARDS is you have a systemic disease. Example, you can get pancreatitis, sepsis, trauma, aspiration, pneumonia, right? So systemic disease, these will release cytokines. Cytokines will activate neutrophils. Neutrophils will cause the release of reactive oxygen species and proteases. Okay, and these proteases and reactive oxygen species will increase the vessel permeability and cause exudation, meaning leakage of protein fluid, and hardening of exudates can cause hyaline membranes. And then you have ARDS. Okay, then you have ARDS. Okay, that's that. Next one. Next one is what happens is, let's talk about the cause. The causes. The causes are sepsis, aspiration, pneumonia, trauma, pancreatitis. These are the causes where you have the release of the cytokines. Okay, then what else? Then what do we expect to find, meaning our findings? Findings. Number one is if we do an X-ray, we find abnormal chest X-ray. Abnormal chest X-ray, meaning that we find ground glass appearance. Then we find respiratory failure. Respiratory failure. Okay, then what we find is we find decreased PaO2, which is the partial pressure of oxygen, by FiO2. FiO2 is basically fraction of inspired oxygen. Fraction of inspired oxygen. Basically, this is the volumetric fraction of oxygen, meaning oxygen in fractionated amounts in the inhaled gas, meaning that in patients of ARDS, the lungs cannot expand. So FiO2 decreases, but PaO2 decreases more. As a result, you have the overall ratio decreasing, PaO2 by FiO2. And then the last one is S. And for S, we have signs, symptoms of respiratory failure without heart failure. Without heart failure. These are the findings. Next one is treatment. Treatment is very simple. First of all, you will treat the underlying cause. Treat the underlying cause. And if that does not work, you will do mechanical ventilation, where you will try to make sure that you give increased positive pressure. So increase positive and expiratory pressure. Why? Because the lungs have the tendency to collapse. So the positive pressure will try to make sure that the lung does not collapse. So it will keep the alveoli firm. Okay, so increase PEEP, and you will decrease the tidal volume, so the lungs do not have to work a lot. Okay, so you will decrease the tidal volume, so to decrease the pressure of the lungs. So you will decrease the tidal volume. That's that. This is your ARDS. Everything broken down into simple, digestible forms. Are you guys clear about this? Yes or no? Are you guys clear about this? Easy to understand? Much better? Okay. Okay, very well. go to the next page. Okay, next page. Next page is sleep apnea. First of all, what is sleep apnea? Sleep apnea is basically, this is repeated cessation of breathing. First of all, how important is sleep apnea for Usmle? For Usmle, sleep apnea is very important. Okay, let me tell you a very funny reason why sleep apnea is very important. One of the highest yield causes of sleep apnea is obesity. Okay, one of the highest yield causes are obesity. Over here in America, do you think that people are more on the slimmer side or on the bigger size, weight wise? Are we a bigger group of people, or are we a slimmer group of people, a fitter group of people? We are considered as a pretty big group of people, right? Because of how cheap our foods are. Okay, do we have any student over here who has ever been to Costco or Walmart's, Kmart, mostly Costco? Okay. Very good, very well. So if you guys know exactly what I'm talking about, that you guys can get very good, cheap, very good foods at a very cheap price. So what happens is we end up being extremely obese. So if you have a generation of people who are extremely obese, sleep apnea, how common is sleep apnea over here in USA? Sleep apnea over in USA is very, very common. Since it is so common over here, sleep apnea is not considered a very high yield disease in any other country, but over here, sleep apnea is very important because it is so common. So first of all, what is sleep apnea? Sleep apnea can be classified into obstructive, central, and obesity hypoventilation syndrome. Number one is sleep apnea. This is repeated cessation of breathing for more than 10 seconds during sleep. So what happens is the patient will come and tell you that when they are sleeping, all of a sudden they will feel like they can't breathe, and they will wake up gasping for air. They will wake up gasping for air. Have you guys ever heard of anyone like this before? Yes or no? Yes. Okay. This is actually pretty common too, on a regular basis. Although in people who are not obese, they're also pretty common because there are obstructive causes too. So that's that. So what happens is that these people, they do not get proper sleep, so they're very tired throughout the whole day, right? How do you diagnose sleep apnea? You diagnose sleep apnea by doing a sleep study. You do a sleep study, and that's how you diagnose sleep apnea. So far, none of this is common. I will tell you exactly what you will see in the questions. Okay. Next one is nocturnal hypoxia. This is high yield. Nocturnal hypoxia. What is nocturnal hypoxia? Basically, if there's cessation of breathing during sleep, would the patients get hypoxic? As a result, what they have is hypoxia can cause pulmonary hypertension, and as a result, they can also cause systemic hypertension, right? And this can cause arrhythmias and sudden cardiac death. People can actually die in their sleep, because when you have cessation of breathing for a long period of time in sleep apnea, in extreme cases, you can actually die from sudden cardiac death. What happens is that from arrhythmia, you get atrial fibrillation and flutter, and obviously it's not controlled in the sleep. And this quickly goes to ventricular tachycardia and ventricular fibrillation, and then it goes to sudden cardiac death. So they can actually die in their sleep. That's that. Another one is these patients, since they are hypoxic, they have increased release of erythropoietin, and erythropoietin causes erythropoiesis. So these patients can have polycythemia. So that's that. Do not forget nocturnal hypoxia. You will receive questions about this in UWorld. Okay, this is high yield. Next one, the three types of sleep apnea. First of all, you have obstructive sleep apnea, central sleep apnea, and obesity hypoventilation syndrome. Obstructive sleep apnea is respiratory effort against airway obstruction. If you have a patient with airway obstruction, then it will be extremely difficult for them to respire. So that's that. So respiratory effort against airway obstruction is obstructive sleep apnea. What happens is that these patients, they have a normal partial pressure of oxygen during the day. Okay, but at night they're pretty hypoxic. That's the thing. What are the causes? The causes are basically, if the patients are obese, so obesity, it is associated with obesity, loud snoring, right, and daytime sleepiness. So they are extremely tired during the day. And what happens is that these patients, the causes are excessive parapharyngeal tissues in adults. Excessive parapharyngeal tissues in adults. Okay. Having said that, did we in our UWorld notes, we discussed a question. I'm not sure if you guys remember a question. If you guys have to, if we have to, there's a question in UWorld. I'm not sure if you guys have received the question or not, that if we have to treat obstructive sleep apnea due to excessive parapharyngeal tissue, what nerve can we stimulate in order to increase the space? What nerve can we stimulate in order to increase the space? Hypoglossal nerve stimulation. Very good. Hypoglossal nerve stimulation. For all the new students who are not being able to answer these questions, you have absolutely nothing to be worried about because we will cover these topics again for you guys in the future. So this is for the students from the previous from our first batch. So that's that. The hypoglossal nerve. Okay, so hypoglossal nerve stimulation. That's that. Do not forget this. For the treatment is CN12 stimulation. Okay. Are we clear about this? Are we clear about this? Excessive parapharyngeal tissue and adenotonsillar hypertrophy, you will stimulate the hypoglossal cranial nerve. This is a UWorld question. Are we clear? Yes or no? Can we move on? Okay. And along with this, the patients, if we try to widen the pharyngeal cavity, yes, that is true. That is correct. Another thing that we can do is obviously if the patients are obese, we can try weight loss. CPAP is continuous positive airway pressure. Okay. CPAP and dental devices. Dental devices. Do you guys remember how we talked about CPAP before? That patients of COPD, they breathe with a pursed lip with a pursed lip breathing. Do you guys remember pursed lip breathing? Yes or no? Pursed lip breathing, pursed lip breathing provides a CPAP, a continuous positive airway pressure, which prevents the alveolar collapse, and they can breathe better. So that's that. So CPAP is also a sleep apnea machine. Basically, this prevents airway collapse. So that's that. So obstructive sleep apnea. Next one is central sleep apnea. What is central sleep apnea? Basically, when the patients are sleeping, and now the defect is not in obesity or anything else. The defect is in the respiratory center in the central nervous system. If they get damaged by injury or some sort of a toxicity or opioids, for example, then the patients can have decreased respiratory efforts, and this can cause Kind-Stokes respiration. What that means is basically Kind-Stokes respiration is apnea followed by hyperapnea and then apnea again and then hyperapnea. That is Kind-Stokes breathing. Okay, and it's very easy to understand what central sleep apnea is that the central sleep apnea once again is due to respiratory center damage of the brainstem. And the causes are also easy to understand. That is opioids and CNS injuries and toxic substances. So if you have to think about central sleep apnea, try to think about three C's. C for congestion, C for CNS toxicity, and C for Kind-Stokes breathing. So these are the three C's. C's. Okay, that's that. Next one is obesity hypoventilation syndrome. Obesity hypoventilation syndromes. Okay. When did I ever get the chance to tell you that I used to be an extremely obese child? Yes or no? Extremely obese. Obese. I was extremely obese. Okay. All I used to do was eat mayonnaise and cheese. Eat mayonnaise and cheese. Okay, my BMI was extremely high, and I remember being extremely out of breath all the time. So, in patients who are extremely obese, for example, a BMI of more than 30 kilogram per meter square, in these patients, do you think that these patients they have a lot of space in their cavities to expand their thorax and start breathing properly? No, of course not. So what happens is that these patients, they're always hypoventilating. They have hypoventilations. And what happens is that these patients, they have increased PaCO2, meaning that their partial pressure of carbon dioxide is more or less all the time high. Obviously, that makes sense because since they're hypoventilating, they're retaining more carbon dioxide. And this increased retention of carbon dioxide also results in decreased PaO2 and increase of PaCO2 during sleep. And this type of findings that the patient has BMI more than 30 and PaCO2 is high. These two findings are very, very high yield for obesity, hypoventilation syndrome. And in UWorld, you will receive questions based on these two findings only. Are we clear? Are we clear about this? Are we clear about this? Isn't he supposed to hyperventilate to compensate? Nope, he cannot hyperventilate because he doesn't have any space in his thorax to expand his lungs. So he cannot breathe properly. He cannot hyperventilate. Okay. Are we clear? So once again, pulmonary hypertension, obesity, BMI more than 30, and PaCO2 is high. This is known as obesity hypoventilation syndrome. Okay. Are you all understanding the lecture? Trying to make it as easy as possible. How many types of apnea do we have? Sleep apneas. How many types of sleep apneas do we have? Can we get some fast answers, please? Can we get some fast answers because I want to move on? Very good. Well, what are the 3 types of sleep apnea? Fast answers, please. Fast answers. Can we get some fast answers? Obstructive and central and obesity. Very good. Obstructive causes. Okay. Obstructive sleep apnea. If you have a patient with obstructive sleep apnea, these patients, what can we do to do these patients have excessive parapharyngeal tissues, which can cause decrease of their, yes, very good. So what can we do to decrease their sign symptoms or decrease their clinical features? What nerve can we stimulate? Okay. Along with that, what can we also do? CPAP. Very good. CPAP. Okay. Next one. Next one is central sleep apnea. What are the causes of central sleep apnea? What are the causes of central sleep apnea? Okay, very good. What are the causes of that's that. Okay, next one. Next one is if you have a patient with increased BMI and increased PaCO2, what will you think of? Very okay. Okay, so that's that. All right. Okay. Are we confident about sleep apnea? Are we all confident about sleep apnea? Okay. Okay. Okay, very low. Okay. Next one is pulmonary hypertension. Pulmonary hypertension. First of all, before we talk about pulmonary hypertension, can anyone tell me what is the normal pulmonary artery pressure? Please don't look at the first aid and tell me, okay? 10 to 15. Okay. 10 to 15 millimeters of mercury. Okay. 10 to 15 millimeters of mercury, more or less, that is exactly what it is. So if you have a patient who with anything more than 15, that's also considered to be okay, but it cannot be more than 25. If it's anything more than 25, especially at rest, then this is known as pulmonary hypertension. What happens if you have long-term pulmonary hypertension? What type of heart failure will you get, left or right heart failure? You will get right heart failure. Okay, so what is this called? Right heart failure due to lung causes. What is the term used for this one? Cor pulmonale. Very good. The term used for this one is cor pulmonale. So basically, if you have a normal mean pulmonary artery pressure, this is 10 to 14, but if it's anything more than 25, then it's pulmonary hypertension. What happens is this results in arteriosclerosis. Arteriosclerosis, meaning that hardening of the arteries, right? Medial hypertrophy, intimal fibrosis, meaning that you have tunica media, tunica intima, right? So the intimal layer will undergo fibrosis due to wear and tear, and the tunica medial layer will undergo hypertrophy, okay, to accommodate the extreme amount of pressure in the hypertension. So that's that. So patients, they get severe respiratory distress, they get cyanosis and right heart failure. And if they have cyanosis and right heart failure, these patients, they die from cor pulmonale. That's that. Okay. Now we have some important causes of pulmonary hypertension. Number one is pulmonary arterial hypertension due to genetic causes. Due to genetic causes. So this is the primary pulmonary hypertension, and this is extremely high yield, guys. Okay, cannot even stretch how important this disease is, because these patients, they're female patients, and these patients have an inactivating mutation in a very important gene. This is known as BMPR2 gene. BMPR2 gene. What this gene basically does is that this will inhibit smooth muscle proliferation. Okay, if there is inhibition of smooth muscle proliferation, this gene prevents hypertension, because if there's excessive smooth muscle proliferation, especially the blood vessels, they're smooth muscles. So if there's excessive smooth muscle proliferation, there is narrowing of the blood vessels. So blood cannot easily pass through. Okay, blood cannot easily pass through here, right? So you get pulmonary hypertension. But if you have a proper functioning BMPR2, then what happens is that the blood vessels, they have a lot of space, and now the blood can easily go through over here, and then there will be no pulmonary hypertension. So that is basically that. So BMPR2 prevents smooth muscle proliferation. If you have an inactive mutation of BMPR2, you have excessive smooth muscle proliferation, and this causes hypertension, especially in female patients. So what you have is you have pulmonary vasculature and endothelial dysfunction, which results in increased vasoconstriction and decreased vasodilatation. So the vasoconstrictors, for example, endothelin will increase, and vasodilators, that is nitric oxide and prostacyclines, will decrease. That's that. And these patients, once again, although it's not mentioned over here, okay, but these patients are mostly female patients. Female patients. Okay, so female patients. Okay. Um, the some other causes. Some other causes are also amphetamines and cocaines. They can cause vasoconstriction, right? So that can also cause arterial hypertension. Then you have connective tissue diseases. In connective tissue diseases, you get also thickening of the vessels. That's also another high yield one. Then you have HIV, portal hypertension, congenital heart disease, and schistosomiasis. None of this are as high yield as BMPR2. Okay, everything else, it will be mentioned in the question, and you can easily associate the diseases, but BMPR2 is the only thing that you have to remember for primary pulmonary hypertension. That's that. Next one. This is the first cause. The next one is left heart disease. Left heart disease is basically if you have decreased functioning of the left heart. If the left heart does not function, then blood will build up in the pulmonary vasculature, and this will cause hypertension. And then you can get right heart failure due to lung causes, and the lung causes are due to left heart failure. So left heart disease. So that's that. This is basically a backup of blood. Then the next one is lung disease or hypoxia, meaning that long-standing obstructive or restrictive diseases can cause hypoxia. And this hypoxia will result in intrapulmonary shunting of blood from a less ventilated area to a well-ventilated area. And then this can cause lung disease or hypoxia. That's that. Very easy to understand. Next one is chronic thromboembolic, meaning that if there's recurrent microthrombi. For example, let's say that we have a patient with factor V mutations, which is one of the most highest yield cause of hypercoagulability in adults, right? And in these patients, if there's always formations of microthrombi, they will go and obstruct the blood vessels. And this obstruction of blood vessels can cause vasoconstriction, and buildup of blood can result in pulmonary hypertension and cor pulmonale. So recurrent microthrombi, that's that. Last one is multifactorial, meaning that if these patients, they have any hematologic, systemic, or metabolic disorders, or for example, if they have a tumor that can press against vasculature over here, this will decrease the blood flow. So these patients can once again have decreased blood flow and increase in hypertension, pulmonary hypertension. That's that. These are very easy to understand. You can easily associate these conditions with pulmonary hypertension, but do not forget BMPR2. for primary pulmonary hypertension. And please write down that they are more common in females. Okay. Why arteriosclerosis? Arteriosclerosis is basically hardening of the arteries for any causes. If there is hardening of the arteries, this decreases the vessel size. So decreased blood can flow through. So blood can build up and cause hypertension, i.e. pulmonary hypertension. Are we clear about this? Are we clear about this? Everyone? Okay. 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 Do we have any students over here who are not medical graduates? Medical graduates. Do we have any student? Do we have any student over here who are still medical students, meaning that maybe they are still in the process of completing their bachelor's? One, and who else? Two, three, four, five, six. Okay. Okay. The reason why I asked you guys this question is because I want to know if you guys have had any experience of working in medicine wards. Have you guys had an experience of working in medicine wards? No. Okay. Have you guys ever completed or have done respiratory system examination or respiratory examination on a patient? Do you guys know what breath sounds, percussion, fremetus, and those things are? Let me give you guys a very small breakdown. Okay, let me give you guys a very small breakdown of what this is. Not so good at it. Do not worry. After this breakdown, you will be very good at it. Okay, you will not be good. You'll be very good. Okay, this is basically very easy to understand. Very easy to understand. Okay. First of all, the lungs. What are the lungs? Lungs are nothing but what I like to think about the lungs are balloons. Okay, air containing balloons. So if there is no air, they they stay, however, okay, although they do not stay collapsed because of the surfactant that's there, but the lungs as a whole, they are nothing but like balloons. So if you have these two lungs over here, right? So if you have this one, okay, and then you have this lungs over here, okay, so you have two lungs, right? Right. Okay. So basically, as a doctor, okay, as a physician, if you have to check if the lungs are okay, there are basically some things which we check. First of all, we do, okay, if we have to break it down step by step. First of all, can anyone tell me what are the steps of respiratory examination? What is the first thing we do? Inspection. Very good. Inspection, then palp for palpitation. I'm sorry, palpation, not palpitation. Okay, my bad. Palpation. Next one, percussion. Very good. And the last one is auscultation. Auscultation. Okay. Okay. So inspection. What is inspection? Palpation, percussion, and auscultation. Inspection is you have the patient who is lying in front of you in anatomical position, right? So you go to the foot of the bed, you look at the patient, and you try to see if the lungs look okay to you, meaning that you try to see the AP diameter, you try to see the respiratory rate, then you try to see if there's any history of a previous surgery. You basically try to visualize the whole chest region as a whole, try to see if there's any chest defect. For example, chest defects such as pectus excavatum or pectus carinatum, or if it's a small patient, if they have anything such as ectopia cardis or any other types of visual lung problems. So that's what you do in inspection. That's that. Palpation. What do you do in palpation? First of all, palpation wise, you try to see if the lungs are expanding properly. So you check for lung expansions, right? You try to put your thumbs over here, your two thumbs like this, and you try to ask the patient to breathe and to see if the lungs actually go far apart. So you try to see lung expansions. And then what else? Then you try to see in palpations are, you try to see if the trachea is in the central place or not, right? To see if there's any deviation of the trachea to this side or this side, because these are very high yield for either lung collapse, right? Or pneumothorax or anything of that nature. So you try to see that. Then what else? Then you try to see what we call is vocal fremitus, or what you do is you have you have the ribs of the patient, right? You have the ribs like this, okay? You have the ribs like this, right? And what you do is you try to place your hand, you try to place your hand this way, okay? You try to place your hand this way over here. And now the thing is, if the lungs are filled with air, if the lungs are filled with air, and if I ask the patient to tell me a word which will resonate, let's say I ask the patient that, sir, could you please repeat the word nine? And the patient goes like nine, 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 nine. And you press and you place your hand over here, right? You will see that if the lungs are normal, then that you can basically feel the word nine resonating on your hands. So that's that. And if there was any obstruction over here, for example, if over here, if you had a tumor, if you had a lung tumor, you will find that the word nine does not resonate properly over here because the solid substance is preventing the spread of the word nine on your hands. But if you do an examination on this side, the patient on which the tumor is not present, and you ask the patient that, sir, could you please repeat the word nine? And the patient goes like 9999, then you can find that the resonation is more over here than here, meaning that over here there's an issue. Either the patient has lung tumor, or there's any type of pneumonia, or water collection, or anything, any type of solid or liquid substances which is preventing the which is preventing the which is preventing the fremitus. So what happens is, in case of a consolidation, for example, pneumonia, if it's a solid pneumonia, the vocal fremitus will actually increase. So if there is a consolidation or a pneumonia, then the vocal fremitus will actually increase over here. But if there is anything like pleural effusion, okay, or let's say pneumothorax or lung collapse or atelectasis, then the vocal fremitus will decrease. That's that. Okay, that is for your fremitus. Next one is percussion. Next one is percussion. Percussion is basically what happens is you have these spaces in between the lungs. You put your hands or your fingers over here. You put your finger over here, and then you try to tap on your finger. What happens is, let's say you put your finger in this spot, right? Before that, have we ever seen, do you guys know what a snare is? Snare of a drum. You know, like how you have a drummer has a cymbal over here, and then they have a snare like this, right? They have a snare like this, and then they have these two tom-toms, right? And then they have another one over here. Then they have a high cymbal over here. Do you guys have you guys like are you guys well acquainted with these structures of the drums? Yes or no? You guys have seen drums, right? Am I correct? Okay, it would be extremely unusual if we have a student come up and tell us that we have never seen a drum. Okay, so basically, if we have this drum filled with air, if there's increased air in this drum, okay, and if you try to percuss, or if you try to tap the top part with your finger, will the sound be really high or really low? Will the sound be really high or really low due to the tone? High or low? If it's filled with air, if it's filled with air, not liquid, if it's filled with air, if you try to tap it with your hands, will it be high or will it be low? It will be really high, right? It will be really, really high. So in the same way, if the lungs are filled with air, if we try to tap on the lungs, will the percussion be hyper resonant or dull? if it's filled with air, hyper resonant or dull. Okay. So normally you have normal sound. Okay. Normally the lungs are resonant. Normally the lungs are not dull, nor are they hyper resonant. Normally the lungs are resonant. So if you tap on the lungs, let's say in a patient or in a person like me and you with normal lungs, if you tap on our lungs, you will find that the sounds are resonating, meaning it's normal. But if you find that the lungs are hyper resonant on percussion, does that mean there's increased air in the lungs? Yes or no? If you try to tap on the lungs and you find that it's hyper resonant, does that mean there's increased air in the lungs? Yes or no? Yes. So if I tell you that there are some causes, for example, pneumothorax, in which you have air, excessive air, then can I tell you that you can have hyper resonant lung findings on percussions? Yes or no? Yes. Okay. And if I tell you that you have a patient with pleural effusion, meaning that there's excessive fluid in the lungs or a solid substance in the lungs, then will the percussion be dull or hyper resonant? Will the percussion be dull or hyper resonant? It will be dull. Okay, very good. It will be dull. Okay, so that's that. That brings us to percussion. Next one. Next one, another thing that we failed to mention on palpation was tracheal deviation. Tracheal deviation. Basically, trachea can deviate, meaning that if we have a trachea over here, right? The trachea will, in a normal patient, the trachea will stay normally in the central. But there are some causes of deviation. The trachea can deviate towards a side. Let's say that if this is the left side or the right side, the trachea can deviate either to this side or to this side. But let's say that the trachea is deviating towards, the word is towards. If it's deviating towards the lesion, that means that a part of this lung has collapsed. Okay, if a part of this lung has collapsed, then the air, it creates a negative pressure which pulls the trachea towards this side. So the causes are usually, if there is a tracheal deviation, then the trachea can deviate to the towards the side. For example, in case of an atelectasis or a lung collapse, that's that. Okay. Another one is if we have the trachea deviate away. For example, now the trachea has deviated towards the left side, but it has deviated away from the right. That's why the trachea is to the left. That means that on the right side, there is a pressure which is pushing the trachea this way, which is deviating the trachea to this side. So for example, in causes such as tension, pneumothorax, where you have lung collapse, but the pressure inside the lungs are so high that the air is pushing the trachea to that side away. So in pneumothorax, you can have the trachea deviate away from the lesion. So now the tracheas are on the left side, but not for the fact that it's towards the left side. It's on the left side because it's away from the right side. Okay, are we clear about this? Are we clear about this? Yes or no? Are we clear about this? Yes or no? Tracheal deviation. Okay. Okay, I will make this clear once again. Do not worry. Okay, next one. Next one is breath sounds. Next one is breath sounds. Breath sound is. Can anyone tell me what is the normal breath sound? What is the normal breath sound in a normal patient? Vesicular. Vesicular. Okay, normal breath sounds are vesicular breath sounds. What do you expect to find in a patient with COPD or bronchial asthma? What is the breath sound in a patient with COPD and bronchial asthma? Vesicular with vesicular. Have you guys heard of vesicular with prolonged expiration? Vesicular with prolonged expiration, yes or no? Anyone? Expiration is prolonged, yes or no? Because of obstruction, yes. So in a normal patient, breath sound is vesicular. In a patient with obstruction such as COPD or bronchial asthma, the breath sound is vesicular with prolonged expiration. For patients with consolidations, okay, the breath sounds are usually bronchial breath sounds, breath sounds, bronchial breath sounds. These are the three types of breath sounds, okay? And over here, you can get vesicular with prolonged expiration with wheezes, right? With wheezing. And over here, if there is pleural effusion or edema, you can get bronchial breath sounds with crackles. Okay, that's that. Okay. Have you guys ever had or seen anyone do um, shisha or smoking from one of those Mediterranean smoke things? Yes or no? Right. So in those things, like how they have this bottom filled with water, right? And then air goes in, and then there's this bubbly sounds over here, like, right? So if you have the lungs which are filled with water, for example, in pleural effusion or pulmonary edema, if you put air into the lungs, right? Let's say that the lungs over here, they're filled with water, and now you breathe in air. Can there also be bubbling sounds in the lungs? Yes or no? Yes or no? So that's that. Okay, so that's basically more or less just the same way that you have bubbles. Okay, so having said that, now let's talk about some of the most high yield physical findings in some lung diseases. Some high yield physical findings in lung diseases. Okay, so first of all, what we will do is we will write breath sounds, then percussion, then vocal fremetus. Okay, you guys will help me finish this. And tracheal deviation, the which way the trachea will deviate. The first disease that I want to talk about is pleural effusion. Pleural effusion. Over here, if you listen to the breath sound, the breath sounds will be vesicular. Okay, the breath sounds will be vesicular, but due to the presence of water, can you hear more of the breath sounds, or will the breath sounds be decreased? Can you hear more of the breath sounds, or will the breath sounds be decreased? Fast answers, please. I need some fast answers from everyone. Very good. The breath sounds will be decreased. If there is water in the lungs and you try to percuss or tap on the lungs, can you hear the tapping more, or will the tapping be dull? The tapping will be dull. Okay. Now, and if the lungs are filled with water and you place your hand and you ask the patient to say 9999, can you hear more resonance or less resonance of the vocal fremetus? Vocal fremetus decrease. So fremetus was also decrease. Tracheal deviation. Will the trachea deviate to either side, or will the trachea stay normally in the same position? It will stay normally, or if any side has a lot of fluid, then that fluid can push it away towards the opposite side. So away if large pleural effusion, if the pleural effusion is very large. Okay, are we clear about this? Are we clear about this? Everyone? Easy to understand or not? Okay. Next one. Next one is the next one that we're going to do is atelectasis. Atelectasis is basically alveolar collapse. The word atelectasis basically means alveolar collapse or lung collapse in microscopic amounts, or if it's a large atelectasis, then there could be a full-on lung collapse. So if you have atelectasis, now If you have atelectasis, what will happen to the breath sounds? Will they be high or will they be low? If the lung has collapsed, there will be normal. There will not be any normal breathing. If there is no normal breathing, then the breath sounds will be low. So breath sounds are low. Next one. Next one is if the lungs are collapsed, meaning that there is less area for the lungs to expand. If you fill the lungs up with air, will they fill up with air? Yes or no? Will they have a lot of air? Yes or no? No. If they do not have a lot of air, when you try to tap on the lungs and percuss, will there be dull percussion or hyper percussion or hyper resonance? Dull. So lung percussion, it will be dull. Okay. What would happen to the vocal tremendous if you try to ask the patient to say 9999? What would happen to the vocal tremendous? Decreased. Vocal tremendous will be decreased. Now, if there's lung collapse, for example, atelectasis, do you remember how we talked about lung collapse and atelectasis? The lung collapse will create a negative pressure, and this will pull the trachea towards the side. Okay, so atelectasis have tracheal deviation. Atelectasis will have tracheal deviation towards the side. So what they will have is they will have tracheal deviation towards the side. 1 second. Okay. They will have tracheal deviation towards the lesion. Okay, so that's that. Okay, next one. Next one is pneumothorax. Pneumothorax. If you have a patient with pneumothorax, what would happen to the breath sounds? Fast answers, please. What would happen to the breath sounds? There will be so much air that the breath sounds will decrease or increase. Can the patient breathe properly? Okay. We will do pneumothorax. There's simple and tension pneumothorax, and both of them, the breath sounds will decrease. Right now, in pneumothorax, does the lungs have a high amount of air or low amount of air? In pneumothorax, high air. If the lungs are filled up with air and you tap the lungs or you try to percuss the lungs, can you hear the tapping more or can you hear the tapping less? High. So these patients have hyperresonance. 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 Okay. What would happen to the fremitus, the vocal fremitus? Vocal fremitus. When you ask the patient to say 9, do you think you can hear it more? I mean, they will resonate more or they will resonate less because there's less amount of air. I mean, there's so much air, less. Very good. So vocal fremitus will also decrease. And then tracheal deviation, it will say normal in simple pneumothorax. And in tension pneumothorax, the extreme amount of air in the lungs can push the trachea away from the lesion, away in tension pneumothorax. Okay, in tension pneumothorax, that's that. Okay, last one. Last one is consolidations. For example, you can have pneumonia or pulmonary edema, right? So consolidations. And consolidations in pneumonia, we talked about the fact how the breath sounds will be bronchial breath sounds. Bronchial. Once again, COPD, bronchial asthma, you have vesicular breath sounds with prolonged expiration. Pneumonia, you get bronchial breath sounds, and the normal breath sound is vesicular. Okay. Now, if you have a solid substance, when you percuss, will there be a dull percussion or will there be a resonant percussion? Dull percussion. So it's a dull percussion. Solid substances, do you remember in basic physics, if you have a solid substance and you try to talk through the solid substance, you can actually hear more because the particles are so well aligned that they can vibrate properly, right? They can vibrate more. So vocal fremitus, if you ask the patient to say 9999, now that they have a solid substance, the vocal fremitus will actually be increased. They will actually be high. And the tracheal deviation, there will be no tracheal deviation. Why? Because they are not pushing or pulling the trachea because there's no change in intrapulmonary pressure. Okay. Are we clear about these findings? Are we clear about these findings? How easy was it? Very easy, right? Consolidation basically means pneumonia, meaning that a part of the lungs which has been consolidified by an infection and uh, used up to cause pneumonia. Basically, that's consolidation. Everyone, is it clear for everyone? The new students, Dr. Han, Dr. Bashir, is it clear for you guys? Atelectasis. Why is atelectasis dull? Because in atelectasis, you have lung collapse. You have lung collapse, so the lungs are not there to expand. So if there's no lungs, there's no air. If there's no air, um, then the percussion is dull. Okay. Emphysema. Emphysema is hyperresonant. Because what happens in bronchial asthma and emphysema is that you have extreme amount of air that is trapped inside the lungs, right? So if you have extreme air that is trapped inside the lungs, then you can have hyperresonance. Okay, then you can have hyperresonance. Next one, in consolidation, why is fremitus high? Fremitus is high because in consolidation is a solid substance, so sound travels faster through solid, right, than liquid and gas. So if there is a solid, then the sound will travel faster in the sense that due to proper alignment of the particles in the solid particles will vibrate properly and the fremitus will increase. It will be higher. Okay, that's that. Any other question? Everyone, any other question? COPD, emphysema, bronchial asthma, everything will be, the breath sounds will be vesicular with prolonged inspiration, percussion will be hyperresonant, vocal fremitus will be decreased, and there will be no tracheal deviation. Okay, are we clear? Everyone? Can we get some answers from the new students to see if they have understood this? Dr. Bashir, Dr. Han, our new students, have you understood this? Okay, very good. Okay. Okay, all right. Next one. Can we move on to the next part of the first aid? Everyone? Okay. Atelectasis. Let's move on to atelectasis. Okay. So this is the table which we have discussed in details in the blank page. Okay. Okay. In consolidations, you can have bronchial breath sounds, inspiratory crackles, egophony, and whispered pectory loci. My apologies. Pectory loci. I always have a hard time mentioning this word. Pectory loci. Does anyone know what that is? Pectory loci. Whispered pectory loci. Does anyone have any idea what that is? What is that one? What is this word called? Anyone? Okay. So whispered pectory loci meaning that, okay, meaning that, let's say that you have a patient over here. Okay, let me take another, okay, 1 second. Okay. Whispered pectory loci. Okay, so let's say that this is a patient who is sitting on a bed. This is the back of the patient, okay? This is the back of the patient, okay? This is the patient's head, and the patient is sitting like this. And this is the back of the patient. So this is the back of the lungs, okay? This is the back of the lungs of the patient over here, right? And you as a physician, you have put your stethoscope over here. Okay, this is your stethoscope, and these are connected to your ears, right? And you are trying to you're trying to listen to this part of the lungs from the back, and the patient has consolidation over here. The patient has a consolidation over here, right? And right now, if you ask this patient to say the word 9999, if you ask him to say the word 9, you will see that when the patient says 9 over here during your palpation, you will find that the vocal fremitus is increased because there is a solid substance. Now if you ask the patient to whisper the word 9 3 times very slowly, and if you put your stethoscope over here, then you can see that if the patient whispers the word 9, then that 9 will be increased, that you can hear the word 9 more in this region than in any other region, meaning that over here, the word 9, um, it sounds extremely normal over here, here, and these portions. But over here, since there's a consolidation, when the patient whispers the word 9, the word is highly resonant with your stethoscope. This is known as whispered pectory loci. Whispered pectory loci. Are we clear?
Yeah.
Are we clear about this? Yes or no? Whispered pectory loci. Okay. 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 Can we move on to the next one? Okay. Let's move on to the next one. The next one that we want to talk about is the next one that we want to talk about is atelectasis. The next one that we want to talk about is atelectasis. Okay. Okay. So atelectasis. Atelectasis is basically alveolar collapse. Do you remember how we talked about atelectasis before? Atelectasis. Yes. Okay. Atelectasis, basically, it's an alveolar collapse. If there's an alveolar collapse, okay, if there's an alveolar collapse, then this is known as atelectasis. The causes are multiple causes. What are some of the causes of atelectasis? First of all, you have obstructive causes or obstructive atelectasis. What happens is that I'm so glad that they have the diagrams over here. This makes things very easy. So what happens over here is that you have an obstruction. For example, if this is a foreign substance, for example, if there's an airway obstruction, this prevents air reaching the lungs, right? So you have an obstruction of this part of the bronchus, right, by a foreign substance. So air cannot go to this or part over here. So the upper part of the lung, this part of the lung, they kind of collapses. And what happens is when when the new air cannot reach this part, then the old air is resorbed, right? The old air is resorbed. If you resorb the old air, this part creates a negative pressure and the lung kind of collapses over here. This is known as obstructive atelectasis. Next one is compressive atelectasis. Compression. If you have a pleural effusion or a tumor which builds up, for example, over here, what this does is when you try to breathe in air, obviously the lungs cannot expand, right? Because of this pressure of the pleural effusion of the tumor. So this compression of the lungs will cause compression atelectasis, which can cause external compression and decrease the lung volume. So that is that. So this is also another type of lung collapse, compression atelectasis. Next one. Next one is contraction atelectasis. Contraction atelectasis is basically if you have a long-term inflammation, for example, sarcoidosis, which is a chronic lung inflammation. This can cause lung fibrosis, and fibrosis can cause, like how fibrosis, they can contract, and if there is deposition of myoepithelium within the fibrosis, then they can contract, and this contraction will prevent lung expansion, and this prevention of lung expansion can cause lung collapse. So basically this region of the lung will stay devoid of air, so they will collapse and the lungs will be like this. That's that. Next one is adhesive. Adhesive is basically if you have neonatal respiratory distress syndrome, for example, if there is no surfactant, then we know that how surfactants are the ones, for example, if this is the alveoli, we talked about how surfactants, they prevent the lung collapse, right? Now, if you do not have any surfactant, then the lungs, what they will do is, now the lung, they will collapse all the way, right? They will collapse all the way. So that's that. So these are the four types of atelectasis. How will you receive questions about this in UWorld? The way you will receive questions about this in UWorld is basically they will tell you that you have a patient who has a foreign body aspiration. Now the patient has decreased respiratory rate, tachycardia, the saturation is decreased. What is the type of atelectasis? If there's an obstruction, the type of atelectasis is obstructive atelectasis. If they tell you that the patient has a pleural effusion, then the atelectasis is compression atelectasis. If they tell you the patient has long-term lung infection or lung inflammation, the atelectasis is contraction atelectasis. And if they tell you that the patient have ARDS or neonatal respiratory distress syndrome, then the atelectasis is adhesive or adhesion type of atelectasis. That's that. Are we clear about this? Are we clear about this? Guys, are we clear? Get some stances, please. First of all, if you have a patient with pneumonia, recurrent pneumonia, right? What type of atelectasis can happen in these patients? What type of atelectasis can happen in these patients? Very good. Very good. If you have a patient with, pleural effusion, what type of atelectasis can happen in these patients? Pleural effusion. If you have a patient with a tumor, what type of atelectasis can happen? Obstructive. Very good. Obstructive. And how about a patient with pancreatitis? Now the patient has atelectasis. What type of atelectasis will that be? Patient with pancreatitis. What type of atelectasis will that be? Adhesive. Okay. Are we confident and clear about atelectasis? Okay. How are we enjoying the lecture today? Are we enjoying the lecture? Are we understanding? We can enjoy the lecture and understand the lecture. So if you are enjoying the lecture, that means you're understanding the lecture. Tumors can also cause compressive. Yes. If there's a large tumor, then they can cause compression. Okay. Okay. Can we move on to the next one? Can we move on to the next one? Okay. Break, please. Break. Okay, let me see. Okay, let me see how much because I really want to finish respiratory system today so that we can jump on to the basic sciences. Okay. Okay. Can we do one more page before we take a break? This will be really easy. Can we do one more? Okay. Okay, the way that we will do this page is, I know that you guys are really tired. Okay, you guys have been doing 2 hours of the lecture full on. Okay, I know you guys are really tired, but this is something which you guys can answer easily. So for this last page, let's discuss right now and then read the first aid. Okay, that's what we will do. The thing that I want to discuss with you is pleural effusions. Okay, the thing that I want to discuss with you is pleural effusion. Does anyone know what pleural effusion, the difference between pleural effusion and pulmonary edema? What is the difference between pleural effusion and pulmonary edema? Basically, this is a very common mistake which a lot of students make. Pleural effusion, okay, so this is the lungs, and the lungs are covered by pleura, right? The lungs are covered by the pleura. right? If you have collection over here or throughout the pleura, right? Over like all the way towards this, because the pleura covers the whole lungs, then this is known as pleural effusion. This is known as pleural effusion. If you have alveoli, if you have alveoli like this, and you have seepage of water or fluid from the alveoli, and that water has filled up the lungs. That water has filled up the lungs because there's so much water leaking from the alveoli inside the lungs. The lungs are now heavy. This is known as pulmonary edema. Okay. Are we clear about this basic finding, this basic knowledge? Pleural effusions and pulmonary edema. Very, very basic knowledge, which a lot of students, they mix up. They're not sure what pulmonary edema is. They're not sure what pleural effusion is. So if we do a thoracocentesis, are we clearing the pleura or are we clearing the pulmonary edema fluid? Which one? Effusion, right? Very good. So we are clearing over the pleura. Okay. So right now, pleural effusion, can I say that pleural effusion is excessive collection of fluid between the pleural layers? Yes or no? Okay. If you have excessive collection of fluid in the pleural region, can the lungs expand? Can the lungs expand? No. No. Okay, no. So this is basically pleural effusion. So are we clear about the definition of pleural effusion? Okay, good, very good. A little more attention is needed, and then we'll be done with pleural effusion. Basically, okay, cannot believe that there's some construction going on right now. Okay, my apologies for this. Do you guys hear a background sound? Okay, good, very good. Okay, good. Pleural effusion. Now let's talk about the causes of pleural effusion. Okay, what are some of the reasons why fluid can leak into the pleura? What are some of the reasons why fluid can leak into the pleura? First of all, if I tell you that you have an infection and inflammation, and there is increase in leakage of fluid in the pleural space, is that a possibility? Is that a possibility? If there's long-term inflammation due to any condition, right? So if the vessel permeability increases, then if the pleural vessel's permeability they increase, then fluid can leak into the pleural space. And if there is leakage of fluid in the pleural space due to inflammation, will this fluid have high protein content or low protein content? High protein content. What is this fluid called? Exudate or transudate? High protein content. High protein content fluid leaking out is known as exudate. Okay, next one. Next one is if we have any condition of the body, for example, in a condition where you have decreased oncotic pressure, where the protein content of the body, it decreases. For example, in heart failure or nephrotic syndrome or liver cirrhosis, what happens is in nephrotic syndrome, you have leakage of protein. I mean, you have increased amount of protein loss in the urine. In hepatic cirrhosis, you have decreased protein formation from the liver, right? Plasma protein formation is decreased. So if the oncotic pressure decreases, then can we have fluid build up in the pleural spaces? Yes or no? Can we have fluid built in the pleural spaces? Yes. Will that fluid be high in protein or low in protein? Low in protein. What is this fluid called? Exudative or transudative? Transudative. Very good. Very good. Okay. Last one. Last one is if I tell you that you have Do you guys realize how every fluid in the body, even the fluid in the pleural space, they are drained out by the lymphatics? We have that basic knowledge, right? Yes, of course we do. Now, if I tell you that there's a lymphatic obstruction, will the fluid not build up over there? Lymphatic obstruction, yes or no? Yes. At the same time, if I tell you that there is a lymphatic rupture, for example, the thoracic duct, right? We have the thoracic duct on the right side. If that ruptures, can the lymphatic fluid leak out from the thoracic duct into the pleural space? Yes or no? Yes or no? Yes. Now, this lymphatic substance that is leaking out into the pleural space, are they high in triglycerides or low in triglycerides because they contain a high amount of cholesterol, the lymphatic fluid? They're high in triglycerides. So the last type of fluid is known as lymphatic. They're also known as chylothorax. Are we clear about this? Chylothorax. Yes. Okay. Okay, so with that being said, we have discussed everything about pleural effusions, hopefully. Now let's read the first aid and we will realize everything is very easy. Okay, now let's read the first aid. First of all, pleural effusions. Pleural effusions, as you have said, it's an excessive collection of fluid which prevents lung expansion. As a result, there is restriction of lung expansion, and this is known as effusion, pleural effusion, and this can be treated with thoracocentesis. Okay. Now, with the first type that we talked about was exudative, where I asked you if there was increased inflammation, will there be leakage? You said yes, and you were right. So there's leakage, and that leakage, I asked you if the protein content is high, and you said yes. So the exudative content is high in protein. It's more than 2.9 grams per deciliters. It's cloudy, and over here, what you have is you have the causes, that is malignancy and inflammation, infection. That those are the causes. You can also get it from trauma. And it must be drained. Why? Because if it stays for a long period of time, this high protein content can cause infections. Because if there's a fluid buildup, which is high in protein, that can cause infection. That's that. So exudative. Next one is transudative, and we asked you if the causes are due to low oncotic pressure, and you said yes. So some of the causes of low oncotic pressure are number one, that is um, in hypocellular one, right? If there's decreased formation, for example, in nephrotic syndrome and liver cirrhosis, or if there's increased hydrostatic pressure, that is heart failure, that is in fluid buildup, you have leakage of fluid. So that's the transudative one. And the last one is lymphatics. Maybe basically, if there's a lymphatic obstruction or there's a lymphatic injury, you have leakage of lymphatic fluids, which are high in triglycerides, and this is known as chylothorax. So these are the two ones. The most important way you will receive questions are by the protein content. That is this one. That is more than 2.9 grams per deciliters and less than 2.5 grams per deciliter. That's that. Okay. And if we look at the picture over here, then this is the normal one, okay? Then this is the exudative one, where you can see that the vessel permeability is increased. The cells are far apart. This creates a space for leakage of the fluid. And then the transudative ones are these ones over here, okay? This is basically a picture of pleural effusion. As you can see, that this should have been the proper lung marking, but over here you have the excess amount of fluid. Which has been collected. The most easiest way you can identify this is your costophrenic and costophrenic and your diaphragmatic angles, which are obliterated over here. So you will have obliteration of this angle and this angle. Usually they are very sharp, as you can see, but in these patients, these angles are not sharp. Costophrenic and costodiaphragmatic angles. These are obstructed or obliterated. Also, if you do a CT scan, you can see that there's the accumulation of fluid over here, pre-treatment, and then after treatment, that is thoracocentesis, the fluid has now decreased. So that's that. Okay, that is what it is. How are questions asked? Questions are asked based on exudation and transudation, whether you know that high protein content is exudative and low protein content is transudative. Okay, are we clear about this? Okay, so now can we take our break?
Dr. Haidari,
Yes, what is your question?
I have a request. Is it possible like do the next pages also like you did it right now, like discuss it and then read first like you did in the past, because it's much easier for me to understand.
Okay, what I will do is, okay, so what I will do is, how about after every page, I will use the blank page. That's what I've been doing recently. Okay, so that everyone is happy, because we have a lot of students who appreciates the use of blank pages, and then we have a lot of students who wants to read the first aid. So what we're going to do is we will do both. First of all, we will read the first aid, and then we will go to the blank pages. So everything is crystal clear. Okay.
Okay, thank you. Yeah, thank you.
Okay, perfect. Okay, so with that being said, can we take our break right now? Okay, how long do you guys want to take a break? 1 hour? 2 hours? Okay, so we will take the break for 15 minutes. Okay, we will take the break for 10 to 15 minutes. I do not want to scare the new students away. Okay, the new students, we do not take breaks for 1 hour. It was just a joke. We were just joking. Okay, we usually take breaks for 10 to 15 minutes. The reason why is because after every 45 minutes, your brain kind of shuts off. Okay, so that's that. Okay, so we will take a break for 10 to 15 minutes, and then we'll come back at 11:30 or 11:32ish. Okay, all right, let's take our break. Okay, is everyone back from their break? Is everyone back from their break? Guys, do we have everyone who's back from their break? Okay, very well, very good. Okay, can we begin the next part of the lecture uh, right now, or do you guys need more time? Okay, I do not want to spend any more time because I want to spend it. I want to finish the respiratory system as fast as possible. Okay, so let's begin with the next part. That is pneumothorax. Pneumothorax is very high yield, and it's a very easy thing to diagnose. Basically, what happens is that right now, instead of liquid accumulating in the pleural space, if liquid accumulates in the pleural space, then this is called pleural effusion. If you have accumulation of air, this is called pneumothorax. What happens is, if you have air accumulation in the pleural space, you have pneumothorax, and the sign symptoms are shortness of breath, uneven chest expansion. So, do you guys remember how we discussed that? And the first thing in palpation is that we try to place our thumbs and we try to ask the patient to breathe in as high as possible, and then we try to see proper symmetric expansion of the lungs. And if it's symmetric expansions, that's normal. If there is asymmetric expansion of the lungs, then it's a finding of pneumothorax. Another thing is, what are the other things? The other thing are that these patients, they will have chest pain, decrease of tactile fremitus. So basically, if you place your hand and you ask the patient to say 9, that sound will be decreased. So decrease in tactile fremitus. Then hyperresonance. Hyperresonance basically meaning that since there is air stuck in the lungs, so that's hyperresonance. And then once again, you will find diminished breath sounds on all affected sides. So these are the physical findings which we have discussed before. I hope you guys remember. Do you guys remember the physical findings we discussed about pneumothorax? Can I get some fast answers? Yes or no? Okay. Once again, what would happen to the breath sound in pneumothorax? Fast answers. Pneumothorax, breath sound. Wrong. Breath sounds are decreased. Breath sounds are decreased. Very okay. Decreased breath sounds. Next one is resonance. What would happen to the resonance? Will it be hyper or dull? Hyper resonance. What would happen to tactile fremitus? Will it be increased or decreased? Tactile fremitus decreased. Tactile fremitus will be decreased. What would happen to chest expansion? Will it be even or uneven? Symmetric or asymmetric? What? Uneven or asymmetric? Very good. Okay, so what are the types of pneumothorax that we have? The types of pneumothorax that we have are primary, secondary, traumatic, and tension pneumothorax. What is primary pneumothorax? Primary spontaneous pneumothorax, a rupture of subpleural blebs, meaning that, let's say that this is the lungs, right? This is the lungs. If you have subpleural blebs like this one, that this is the pleura, right? And beneath the pleura, you have these bleb-like structures of the lungs, okay? Especially from, let's say, an infection or from smoking or something like this, right? That you have subpleural blebs. If these blebs, if they rupture, if you have rupture of these blebs, right? If you have rupture of these blebs, then this has a potential space for air to come out. So what happens is that what happens is now that you have this space, right? Now that you have this space in the lungs, and this is the pleura, right? So what happens is the next time when you breathe air in the lungs, this air, it goes through this valve. But the thing is, it's a one-way valve. What does that mean? Meaning that air can go through here, but air cannot come out through here and leave outside. So what happens is it cannot do that. So what happens is that it's a one-way valve, meaning that air will come in and air will keep on accumulating over here. So what this will do is the more you breathe, the more air accumulates in the lungs, I mean in the pleural space, and this pushes your lungs upward, right? So this collapses your lung, and what you have is this excessive accumulation of air results in the lungs being from that previous structure to this one, this previous structure, and all this part is air. And all this part is air. So this excessive amount of air due to the presence of this one-way valve. So what you do is, what we do is we try to release the tension in the pleural space. We try to release the tension in the pleural space. The way that we try to do this is we try to do needle decompensation and chest tube. So we place a chest tube over here. What we do is we try to place a chest tube. We place a tube over here. So right now, all this air that was accumulated, they can leave, and now the lungs can, and then the lungs can take back its regular shape. So this is the whole basic knowledge behind pneumothorax. Are we clear about this? Yes or no? Are we clear about this? Yes. Okay. Is the valve a one-way valve or a two-way valve? One valve. The valve is a one-way valve. Okay. So the primary one is due to rupture of subpleural blebs. Okay. The secondary one is due to diseased lung. If there's a lung disease, okay, then the next one is if there's a lung disease, then lung diseases will result in formation of infections and blebs, and then those will rupture, and then those ruptured ones will result into secondary pneumothorax. That's secondary pneumothorax. Next one is traumatic. Traumatic is, for example, right now, instead of having a bleb or an infection, if you have a puncture, for example, someone comes and stabs you, and now you have this part stabbed, right? And now this is also a potential one-way valve created for air to come out and then accumulate in the pleural space and cause pneumothorax. So traumatic pneumothorax is also another one. This is caused by blunt trauma or penetrating trauma, or this can be caused by barotrauma, okay, or iatrogenic. Iatrogenic means central line placement. So that's that, meaning that, for example, if you try to place a central venous pressure line, you can actually rupture the apical lungs, and that can also result in traumatic pneumothorax. That's that. Okay. Next one is tension pneumothorax. Tension pneumothorax, once again, it can be from any one of the above. That is, it can happen from trauma, infection, rupture. And what happens is that in tension pneumothorax, the air that is trapped causes tension, and this air will deviate the trachea away from the affected side. So what happens is that there's so much air in the pleural space over here that this space, it creates a force on the trachea, and the trachea deviates towards this side, right? And also what this does is this side, if this is the right side, then this can cause mediastinal displacement, and this extreme amount of pressure can cause your tension in the inferior vena cava. And this inferior vena caval tension results in decreased venous return to the heart, and this decreases the cardiac output. As a result, patients can also die from shock, from cardiogenic shock. That's that. Okay. So once again, how will you treat these patients? You have to release the tension. How will you release the tension? You have to place a needle. You have to do needle decompensation and chest tube placement. Okay. Are we clear about this? Every one of them can have tracheal deviation if the amount of pneumothorax is high. Okay. Okay, Dr. Jordan, no problem. Okay. Okay. Once again, let me discuss this once again. Okay. Okay. Everyone, please stay with me on this one. Okay. Except Dr. Jordan, if you have to leave, no problem. I'm going to send you the video. You can watch it later. No problem. Okay. Okay. The issue is, first of all, over here, you can have some problems. The first thing about pneumothorax is you have to have a valve. Normal lungs, they do not have any broken structure or broken apparatus, so there's no valve over here. If you have an apical bleb, or if you have an infection which results in the formation of a bleb, this bleb can rupture, right? This bleb will keep on expanding, and then at one point it will rupture. If it ruptures, then you have the formation of the valve. Then this valve has been created. Now, every time, okay, let me draw the pleural lining, okay, okay. Every time you breathe in air, air comes in to the pleural space, but it cannot leave the pleural space. So air builds up over here. This causes the tension. This is known as tension, okay. This tension will result in the lung collapse. This lung will collapse to over here. This is what will happen to the lungs, and there will be so much air over here that the lungs will be collapsed. So the way you can manage these patients is if you place a chest tube over here, this air can leave and the lungs can go back to its regular shape. Okay, that's all I've been talking about. Primary one is the one from the formation of apical bleb. Secondary is secondary to lung infection, meaning lung infection can also result in blebs. And traumatic is instead of having a bleb or an infection, if you have an injury, example, a stab injury or a blunt trauma or a gunshot wound, then again, a valve can be created and air can leave and form over here, and this can result in pneumothorax. That's that. Okay, so that's exactly what I'm talking about. Have you guys understood this? You guys understood this now? No. In atelectasis, lung collapse is happening because of obstruction, compression, then contraction, and adhesive reasons. That is atelectasis. Over there, the percussion, it will be not resonant. But pneumothorax, lung collapse is happening because of increased amount of air. So this increased amount of air will cause hyperresonance. Now, are we clear? Are we clear now? Okay, okay. Write this down. This is high yield. Write this down. What is the location for chest tube placement? Location for chest tube. Write it down in your book. Location of chest tube placement. What is the location where we place the chest tube? The location is anterior axillary line, anterior axillary line at fifth intercostal space, or the fifth ICS. Okay. Do you guys write it down? Anterior axillary line at fifth intercostal space. Okay. First of all, we make a skin incision, and then through that skin incision, we place a chest tube, and we make sure that the chest tube is a two-way valve. Okay. Are we clear about this? It's a very high yield UL question. Okay. If it's a hemothorax, okay, if it's a hemothorax, not a pneumothorax, if it's a hemothorax, for example, if there's collection of blood in the pleural space, okay, if it's a hemothorax, then the intercostal space is that second or third intercostal space. Also write that down. Okay. Okay. Awesome. If it's a hemothorax, the space is at the third or second or third intercostal space. Okay. fifth intercostal space for pneumothorax, second and third intercostal space for hemothorax. Okay. Okay, next one is from Dr. Ibrahim. Is above or lower border? Above or lower border? It's in the middle between the ribs and the pleural space. Be Okay, second or third intercostal space. Why is it at the second or third intercostal space? The reason why it's at second and third intercostal space is commonly we can give it at intercostal space because the fluid collection is at the bottom. That is true, but usually what happens is in hemothorax we usually give it at the we give it at a second or third intercostal space at the mid-clavicular line, which is a potential space for the collection of the blood. That's why. Okay. 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 At the anterior, okay, once again, pneumothorax, anterior axillary line, we give it at fifth intercostal space. If you want to give the chest tube at mid-clavicular line, then we give it at second or third intercostal space. Write it down. If you want to give the chest tube at mid-clavicular line, then you have to give it at second or third intercostal space. Okay. Did you guys write it down? Okay. So are we clear about pneumothorax? Okay. Are we confident? Okay. Okay, let's move forward. Okay, let's move forward. That is pneumothorax. Okay. Right now, we will talk about pneumonia. Okay. Does anyone know what pneumonia is? Have we ever heard of pneumonia? Ever? Of course. Okay. Of course, we have heard about pneumonia. Pneumonia is a very, very common lung infection. What is pneumonia? Pneumonia is basically consolidation of a lung due to accumulation of a microscopic or microorganism. That is pneumonia. How many types of pneumonia are there? First of all, you have lobar, where an entire lobe is affected. Then you have bronchopneumonia, which are patchy opacities. Then you have interstitial pneumonia, which are atypical. And then you have cryptogenic pneumonia, where the causes are unknown. First of all, what are the organisms that can affect an entire lobe? We will read these organisms in details in microbiology in a couple of days. But the organisms are Streptococcus pneumoniae, which is most common for lobar pneumonia. So please do not forget this. If you have a chest X-ray like this and an entire lobe of the lungs are affected and they ask you what is the most common organism, the most common organism is Streptococcus pneumoniae. Also Legionella and Klebsiella, they're also pretty high yield, but that's that. What are the characteristics? Intraalveolar exudate. So there's exudation resulting in consolidation. Once again, if we have consolidation, what would happen with the breath sounds? Last answers, please. What would happen to breath sounds on consolidation? Bronchial, remember, not decreased. Breath sound is decreased. The breath sound is bronchial breath sound. Next one, what would happen to percussion? Percussion, dull or hyper? Dull. What happen to vocal fremiters? Increased. What would happen to the tracheal deviation? Tracheal deviation. No deviation. Very good. That's that. Okay. Next one, bronchopneumonia. Bronchopneumonia, the most important causes are Streptococcus, Staphylococcus, Haemophilus, and Klebsiella. These are the 4 organisms. That's that. Okay. The best way they will describe you these organisms is they will try to describe these organisms according to their microbiological properties. So in order for you to identify these organisms, you have to study microbiology. So we'll leave it at that. Okay, what would happen is you have an infiltrate from bronchioles, then you have patchy distribution, which will affect more than one lobe. For example, like this one, this type of patchy distributions. Uh, Wait, this is not for that one. 1 second. Let me show you a bronchopneumonia picture. Bronchopneumonia, patchy opacities. Okay, these type of patchy opacities. These are for bronchopneumonia. I'm pretty sure you guys have seen this before. This is very common in high yield. Next one is atypical pneumonia. Atypical pneumonias are pneumonia which are caused by atypical organisms. For example, mycoplasma, chlamydia, then chlamydia chlamydia pneumoniae, and chlamydia psittaci. These are atypical organisms. Then you have Legionella, and then you have the viruses. Viruses, for example, respiratory syncytial virus, cytomegalovirus, influenza, and adenovirus. Once again, these questions will come according to their microbiological properties. So reading them in microbiology is more important. So right now, just read through them. It's not high yield uh, for at least the pathology. Okay, so for microbiology, this is very high yield. For lobar pneumonia, please don't forget that Streptococcus pneumoniae is number one. Next one is atypical pneumonia. How will you identify atypical pneumonia? This is basically patchy inflammation, like this one's over here, more or less a little like bronchopneumonia. And chest X-ray will show bilateral multifocal opacities over here. The multifocal, there will be opacities. And this is basically a walking pneumonia, meaning that how when someone will when someone has a lung infection, very out of the ordinary, out of nowhere, uh, then there's a high possibility then the pneumonia is interstitial pneumonia or atypical pneumonia, basically meaning that maybe they were walking through some sort of a place where these organisms were accumulated in the air as droplets or droplets infection. So that's that. As a result, the courses are more indolent course. So that's that. Next one is cryptogenic. Cryptogenic basically means the causes are unknown, and it's secondary to chronic inflammation. For example, in rheumatoid arthritis, sarcoidosis, or any type of medications, for example, amiodarone, which causes pulmonary fibrosis, these can cause some sorts of consolidations. These consolidations can get infected or not infected, but the consolidations as a whole, due to these conditions, are known as cryptogenic, meaning that the causes are not known. Meaning that if you do a sputum culture over there, there might not be any bacteria. So negative sputum and blood cultures. That's that. It was formerly known as BOOP, meaning bronchiolitis obliterans organizing pneumonia, but nowadays it's being called as cryptogenic. It's a non-infectious pneumonia which is characterized by inflammation of bronchioles and surrounding structures. That's that. Okay, so that's all about pneumonia. Okay, are we clear about this? Are we clear about all the different types of pneumonia? Patient looks good, but X-ray is very bad. Very good. This is the type of finding in atypical pneumonia. That's that. Are we clear about this? X-rays look sicker than the patient. That is true. That is correct. Are we clear about the types of pneumonia, guys, so that we can move forward? Yes or no? Very easy to understand. Okay. Okay. Next one. Okay. Next one. Next one that we want to go to is the natural history of pneumonia. Okay, the next one that we want to go to is natural history of lobar pneumonia. Natural history of lobar pneumonia. Before we talk about this, I want to talk about this in a separate page. Just that I'm blank page. I want to go to this one. Okay. So first of all, natural history basically meaning that what are the findings of the lungs according to the days of which pneumonia has occurred. Okay. So what happens is you have the days. Okay. You have the days and you have the findings. Okay. You have the findings. Okay. So what's happening over here is that first of all, in the first 2 days, that is 1 to 2 days, what you have is you have congestion, meaning that this is right after, this is right when the pneumonia is taking place, right? So you have congestion, meaning that everything is congested, right? Basically meaning that you have accumulation of all the products of the blood, right? And the characteristic and findings are accordingly, meaning that the lungs, they appear congested, that they appear red or purple, red or purple appearance of the lungs. And this is basically in the first 2 days. So they are filled with exudates. They are filled with exudates and bacteria. So that's that. So that is congestion. That is the first 1 to 2 days. After the first 1 to 2 days, what happens is the exudate that stays over here in the next 2 days, that is in 3 to 4 days, what you get is you get red hepatization. Red hepatization, hepatization meaning that it basically looks like a red liver. Because what happens is that all this red congestion and this red exudative findings, they're all broken down, right, by fibrin, bacteria, RBC, WBC. You have all these reactions going on over here. So the appearance, they look red-brown. Okay, because whenever you have accumulated substance, your white blood cells will go and attack them. And due to all this attacking, there will be formation of a consolidation, and this is red-brown hepatization. After all this fight between the exudates, bacteria, and the white blood cells, you have the red brown, and then there is resolution, meaning that there is formation of broken down RBCs, broken down WBCs, and deposition of fibrin, resulting in temporary fibrosis. So what happens is you have gray hepatization. Gray hepatization is for 5 to 7 days, and over here the color is gray. And then the last one is after 8 days, what you have is you have all of these things which are broken down once again by enzymes that are released from macrophages and then cleared away by lymphatics. So there is a resolution. The last stage is resolution. That is after 8 days. And over here, the color is uniform color. Okay. Okay. So these are the findings. First is red purple, red brown, gray, uniform. So according to the findings, they might ask you what day is it of the infection. These are the answers and these are the questions according to the findings. The findings will be there in the questions. Are we clear? Are we clear about this? Are we clear about this? Okay. Red brown color, which day is it? Red brown color. Fast answers, please. Red brown color. Lung. Gray color of the lungs. Answers. Form color. Okay. Then what else? Okay. So let's go back. Let's go back to this one. Findings. First of all, you have 1 to 2 days. You have red purple, with there's partial consolidation, exudation with bacteria. Don't forget that the questions will come from here and the answers are the days. Then you have red hepatization, where there's red-brown consolidation, exudate with fibrin, bacteria, RBC, WBCs, and they're reversible. And then there's gray hepatization, in which you have uniform gray color, broken down of RBC, WBC, and fibrin. And then the last one is enzymatic digestion by macrophages. So that's that. Color is uniform over here. Are we all clear and confident? Are we all clear and confident about this? Yes or no? 5-minute break, please. Then okay. Let me come back 5 minutes. Okay, is everyone back from the break? Okay, can you guys hear my voice? Is the voice clear? Is the voice breaking? Can you guys hear my voice? Okay, are we ready to begin the next part of the lecture? Okay, perfect. Okay, let's begin the next part. The next part of the lecture that we want to talk about is lung carcinoma. Lung carcinoma. What happens when you study carcinoma at the end of the chapter? Does that mean that we're really close to finishing the chapter? Yes or no? Right? After every chapter, at the end of every system, you have carcinoma. When you reach carcinoma, try to realize that you are very close to the end of the chapter. Okay, carcinoma, lung cancer. Lung cancer is one of the most leading cause of cancer death. The mortality over here is very high, and the prognosis of treatment is usually not that very high until and unless it's caught in a very early stage. So that's that. If it's an early stage, then with no metastasis, it's actually kind of treatable. So that's that. But in most of the cases, the lung cancer stays silent for a long period of time, and it's diagnosed at a very high stage. That's that. Okay. What are the presentations of lung cancer? Let me ask you guys. What are the presentations of lung cancer? A patient with lung cancer, what do you think they will have? Can I get some fast answers, please? The very basic knowledge. What are the cough? Then, then what else? Cough, shortness of breath, chest pain, hemoptysis. Am I right? Wheezing, right? Yes. So those are the things. So cough, hemoptysis, shortness of breath, bronchial obstruction, wheezing. Then you can get atelectasis, right? You can get obstructive atelectasis or compression atelectasis. That's that, right? And then when you do a chest x-ray, you can find that there's a coin lesion. This is very high yield. If they mention that on chest x-ray of a patient in UWorld that they found a coin-shaped lesion, then try to realize they are directing you to a lung cancer question. Coin lesion, the word is coin. Coin, please don't forget this. Coin lesion on x-ray. This means lung cancer. What are the sites of metastasis of lung cancer? Well, the sites of metastasis are liver, adrenals, blood, bone, and brain. Liver, adrenals, bone, and brain. And lung mets love effective boneheads and brainiacs, meaning that lung cancer, they affect the liver, adrenals, bone, and brain. That's that. Okay. In the lung, the metastases are common. That is in lung, the metastases are more common than primary neoplasm, meaning primary lung carcinoma, that is carcinoma arising from the lungs, they are less common than the most possible reason for the primary metastasis for lung carcinoma is the fact that it has metastasized from somewhere else. Most oftenly, they can metastasize from the breast, colon, prostate, and the bladder. Breast, colon, prostate, and bladder. These are the 4 locations from where lung cancer can metastasize from. And liver, adrenal, bone, and brain are the ones where they will metastasize to. So please don't confuse these both. One is breast, colon, prostate, and bladder cancer. Carcinomas of these regions can metastasize to the lungs. That's one. And liver, adrenal, blood, bone, and brain are the ones where the lung cancer can metastasize to. Okay, so that's that. Okay, what are the complications? Complication is, first of all, you can have a very important complication that is superior vena cava syndrome or thoracic outlet syndromes. Have you discussed about this in cardiovascular system, CVS? Thoracic outlet syndromes, CVS. What happens? Have we discussed about this in the CVS? Can I get some fast answers, please? Oh, in musculoskeletal. Okay. Musculoskeletal. Have we discussed about this before? That is a question. Have we discussed about this before? Superior vena cava syndrome. Basically, superior vena cava syndrome. Do you have in superior vena cava syndrome, do you have bilateral swelling of the hands or unilateral swelling of the hands? Fast answers, please. Bilateral swelling of the hands or unilateral swelling of the hands? Everyone? Where do you have bilateral swelling of the hands? Bilateral swelling of the hands? Can I get some fast answers, please, or we have to move on? Okay, answer me this. Do we have facial swelling and plethora? Do we have facial swelling and plethora? Okay. Now, unilateral swelling, why will this be more common in superior vena cava? And superior vena cava, isn't it more common for bilateral swelling of the arms? Bilateral. Why? Why is bilateral swelling of the arm? Why is this not common in superior vena cava syndrome? Can I get some fast answers, guys, please? Okay. You know what? As a matter of fact, superior vena cava syndrome, this will remain as a homework. What you guys will do is you guys will learn more about superior vena cava syndrome and brachiocephalic outlet syndrome. And I will ask you guys questions about this tomorrow, okay? Because I want to finish this today. So superior vena cava syndrome, basically what that means is you have, if the tumor goes and it obstructs the superior vena cava, then blood from the superior vena cava, it cannot drain. So if blood from the superior vena cava, it does not drain, then everything from the upper extremities to the head, they get engorged. So patients can get facial plethoras and arm swellings. That's that. Next one is Pancoast tumor. Pancoast tumor is basically apical tumor, meaning that if this is the lungs, this is the apex of the lungs. If the tumor is over here, then this is the Pancoast tumor. The problem with this tumor is that Pancoast tumors, they compress the cervical ganglion. When they compress the cervical ganglion, they cause ptosis, meiosis, and hydrosis. That is Horner syndrome. Then patients can also get paraneoplastic syndromes, for example, ectopic PTRH, P secretions, ectopic ACTH secretions. And then you have another nerve over here that is recurrent laryngeal nerve. If the tumor compresses the recurrent laryngeal nerve, patients can get hoarseness, or long-term tumor can cause release of inflammatory cytokines, and this can cause effusion. That's that. What are the risk factors? Risk factors are basically, number one is smoking or secondhand smoking, asbestos, radon, and positive family history. Those are the risk factors. And there are two types of lung cancers which arise by smoking. Both of them are central in position. Both of them are caused by smoking, and both of them starts with the letter S. That is squamous cell carcinoma and small cell carcinoma. Okay, squamous cell carcinoma and small cell carcinoma. Are we clear about this? Yes or no? Are we clear about this? Okay. Next one. Next one is small cell carcinoma. Okay. Small cell carcinoma, once again, I'm going to go to the blank page so that we can understand everything. Okay, I'm going to go to the blank page and then we can come back to the first aid. Okay. So small lung carcinoma, there are some types of lung carcinoma. Okay, so first of all, type of lung carcinoma, then properties of lung carcinoma or characteristic of lung carcinoma, then histology of lung carcinoma. That is, what do we see on the histology? Okay. Number one, what is the type? Type is, first of all, lung carcinoma can be broadly classified into small cell and non-small cell type. So number one is small cell lung carcinoma. Small cell lung carcinoma, what are the properties? First of all, what is the location of small cell lung carcinoma? Can I get some fast answers? We just read about this. What is the location of small cell lung carcinoma? And what is the number one risk factor for small cell lung carcinoma? What is the number one risk factor for small cell lung carcinoma? Okay. If there has to be an emphysema in patients of small cell lung carcinoma, what type of emphysema can there be? Predisposed previously to the development of the carcinoma? Centria signer, very good. Dr. Dahlia, very good. Okay, so properties. First of all, location-wise, it's central. Okay, the cause is smoking. Okay, the cause is smoking. Over here. Okay, and now next one is if we do a histology of small cell lung carcinoma. On histology of small cell lung carcinoma, small cell lung carcinomas are neuroendocrine tumors. Neuroendocrine tumors. If they are neuroendocrine tumors, do you guys remember that we talked about the fact that every neuroendocrine tumor is positive for three types of stains, that is chromoganin, synaptophysin, and neuron specific enolase? Yes or no? Neuron specific enolase. Do you guys remember that? That we talked about the fact how chromogranin, basically every neuroendocrine tumor is positive for three types of stains. Those stains are chromogranin A, then synaptophysin, and neuron specific enolase. These are the three things that are positive for. At the same time, what you can find in small cell lung carcinoma are small dark blue cells called Kulczycki cells. They are called Kulczycki cells. Kulczycki cell. These are small dark blue cells. Okay, small dark blue cells. Okay, this is basically all the things that you need to remember regarding the properties, type, and histology. Now, the next thing that we want to talk about, lung carcinoma, that is small cell lung carcinoma, are the paraneoplastic syndromes. The paraneoplastic syndromes, small cell lung carcinoma, are, first of all, they can have ACTH production that can cause Cushing syndrome, ectopic ACTH, ectopic ADH that can cause SIADH, that is syndrome of inappropriate antidiuretic hormone secretion. Then they can have Lambert-Eaton myasthenic syndrome, that is antibodies against presynaptic calcium channels, resulting in the decreasing or release of acetylcholine. Or they can have paraneoplastic encephalitis or myelitis or subacute cerebellar degeneration. Do you guys remember we talked about anti-WHO, anti-yo, anti-this, anti-that for the paraneoplastic encephalitis? Yes or no? Okay, so that one was for small cell lung carcinoma. Okay, they can be managed with chemotherapy or radiotherapy. Okay, they can be managed with chemo or radiation. Are we clear about this? They can be managed with chemo or radiation. So so if I ask you, what are the paraneoplastic conditions? It's ACTH, antibody against presynaptic calcium channels, right? And ectopic ADH, all the A's. Are we clear about this? Are we clear about this? Yes or no? Okay. Okay, all right. Now, let's talk about the pathology. The pathology of small cell lung carcinoma, basically, if we have to talk about the pathology, it's caused by amplification of MYC oncogenes. It's caused by amplification of MYC oncogenes. Are we clear? MYC oncogenes. Okay. The way I remember small cell lung carcinoma and MYC oncogene is MYC is my carcinoma. Small carcinoma is my carcinoma. So MYC is my carcinoma, MYC. Okay. Are we clear about this? My carcinoma, my MYC for small cell lung carcinoma. Okay. Is it clear? Is it clear? It's not clear? Why is this not clear? What's your question? What's your question, Dr. Mohammed? What are you confused about, please? Could you please let me know what your confusion is? Would you be kind enough to unmute yourself and ask what your confusion is? I will clear it right away. Okay, please unmute yourself and ask me your question. Let's have a proper discussion.
Doctor, you spoke about something endocrine. I don't know what you spoke about actually.
Oh, you're not sure about the paraneoplastic conditions? Is that what it is?
Yeah.
Okay, good, very good. Thank you so much for your question. Basically, paraneoplastic conditions, the word paraneoplastic, meaning that there are certain cancers which releases hormones, okay, that are not secreted from the primary region. So, Dr. Mohammed, if I ask you right now, where is ACTH primarily secreted from? ACTH, where is this primarily secreted from? Can I get some fast answers from you, please?
From the
adrenal glands, right? From the adrenal glands?
Yes.
Okay.
Yes.
Okay. I'm sorry, my apologies. ACTH is not secreted from the adrenal glands, it's secreted from the pituitary glands, right? And then they go and stimulate the adrenal glands to secrete cortisol. That's basically like what it is. But over here, instead of the pituitary gland secreting the ACTH, if the ACTH is secreted from a tumor of the lungs, then this is known as paraneoplastic, meaning the hormones are being secreted from another neoplasm or a tumor. So that's that. This is known as paraneoplastic condition. Ectopic ACTH is known as, it's one of the paraneoplastic. Then these cancers can also secrete another hormone such as ADH, which can cause SIADH. They can also secrete antibodies instead of hormones, and they can cause Lambert-Eaton myasthenic syndrome, where they will prevent calcium entry and decrease the release of acetylcholine. So that's that. And some of them can also be peptides, for example, parathyroid hormone-related peptides, which are released from squamous cell carcinoma. That is also a paraneoplastic syndrome. Paraneoplastic syndrome, once again, are the syndromes which are occurring out of the ordinary due to the presence of neoplasm. Are we clear about this? Okay.
Okay, doctor. Thank you very much.
Okay, you are welcome. Okay, Dr. Salim, no problem. Okay, we will send you the videos. Okay, next one. Next one is adenocarcinoma. Adenocarcinoma, first of all, what is the location of adenocarcinoma? Can I get some fast answers, please? If it's not central, then what is the location of adenocarcinoma? We know that two of the tumors are central, that is squamous cell carcinoma and small cell carcinoma, and which are not central. So adenocarcinoma, what is the location? Adenocarcinoma, the location is peripheral, very good. Adenocarcinoma. Okay, this is more common in non-smokers. Non-smokers are more prone to have adenocarcinoma, and they are more common in women or in females. That's that. Okay, right now, if you do a histology of adenocarcinoma, what do you find in a histology of adenocarcinoma? Adenocarcinoma, the word adenocarcinoma means carcinoma of a glandular or a gland. Am I correct? Carcinoma of a gland. Adenocarcinoma, meaning a glandular carcinoma, right? So on histology, can it have a very glandular pattern? Can it have a very glandular pattern? Yes or no? Yes. And what was the most important gland in the lungs on normal histology? Do you remember that most of the glands in the lungs were responsible for secreting mucus? Yes or no? Mucus, so goblet cells, right? Am I correct? Goblet cells. Okay. So if I tell you that you have carcinoma of those glandular patterns, then can there be tall columnar cells which are secreting a lot of mucus? Yes or no? Tall columnar cells secreting a lot of mucus. So on histology, what you find is, first of all, you find glandular pattern, and you find tall columnar cells with mucus. Okay, are we clear? Are we clear about this? Is it easy or not easy?
هي اللي بتكتب اللي بيقولها.
Okay. Is it easy or not easy? If you have background noises, please refrain from unmuting yourself to prevent disturbance. Okay, for the other students. Okay, all right. Next one is, I want to tell you a story about three of my friends. Okay, three of my friends. Have you heard the story of three of my friends who got diagnosed with lung carcinoma? Yes or no? Okay, from Dr. Krabasi, why can it cause Cushing syndrome, small cell lung carcinoma? Is it due to paraneoplastic syndrome? Yes, that is due to paraneoplastic syndrome. That is paraneoplastic syndrome. Okay, ectopic ACTH. Okay, my question is, have you guys heard of three of my friends who got diagnosed with lung carcinoma? Three of my female friends who got diagnosed with lung carcinoma? No? Have I never mentioned these three friends of mine? Okay, it was very unfortunate. Okay, both of them were women. I mean, all three of them were unfortunately women. They have never smoked a cigarette in their life. My friends, I basically grew up with them. Very unfortunate that they left. Okay, one was Kate, another one was Esther. Okay, very close friends of mine, but for some reason, I don't know why, all three of them had lung cancer, and unfortunately, all three of them passed away. So these are the three friends of mine. Can you guys remember these three friends of mine, please? And do not forget about them. Okay, Kate, Esther, and Allie. Okay. The reason why I want you guys to remember these three friends of mine are, if you have activating mutation in KRAS, if you have activating mutation in EGFR, if you have activating mutation in ALK, then you can get adenocarcinoma. Can I give you guys 10 seconds to remember this, please? Try to take 10 seconds. Okay, so who are the three friends of mine? Can you guys tell me the names of three of my friends? Can you guys tell me the name of three of my friends? Three of my friends who passed away from lung carcinoma. Kate, Ali, and Esther. What are the three activating mutations that can result in adenocarcinoma? KRAS, EGFR, and ALK. Okay. Okay. Next one. Next one is patients of lung carcinoma. They will also have another paraneoplastic finding. The paraneoplastic finding which they will have is known as hypertrophic osteoarthropathy, meaning that they can have bone pain, or usually what happens is they have clubbings. Okay. What is this clubbing? Is this the clubbing where lung cancer patients, they go to the club at night and dance their sorrow away, dance their pain away? Is it that type of clubbing? Yes or no? What type of clubbing is this? What type of clubbing is this? It's the drumstick appearance of the fingers. Okay, this is the drumstick appearance of the fingers. Are we clear? Okay. Okay, so with that being said, let's look at the text. So first of all, we have adenocarcinoma, that is peripheral. This is the most common primary lung carcinoma, most common in women. They have activating mutations in KRAS, EGFR, and ALK. They are associated with hypertrophic osteoarthropathy, right? This is high yield. Bronchoalveolar subtype, adenocarcinoma in C2. Adenocarcinoma in C2 is known as the bronchoalveolar type. This is not high yield. Don't worry about this one. Then chest X-ray shows hazy infiltrates, which are similar to pneumonia. And the prognosis of adenocarcinoma is actually better than small cell lung carcinoma. That's that. If we do a section, then what we can find is glandular patterns, which will be positive for mucin, meaning that they will secrete a lot of mucus. That's why it's positive for mucin. Then over here, you have thickening of alveolar walls and tall cells secreting mucus. Tall cells secreting mucus is highly diagnostic of adenocarcinoma. It's highly diagnostic of adenocarcinoma. Are we clear about this? Are we clear about adenocarcinoma? Are we clear about adenocarcinoma? Okay. Can we move on to the next one? Okay. Okay. Next one. Next one is squamous cell carcinoma. Squamous cell carcinoma, once again, if I have to talk about squamous cell carcinoma, then what is the location of squamous cell carcinoma? What are the two cancers that are central? What are the two carcinomas that are central? What are the two centrally placed carcinomas? Small cell lung carcinoma and squamous cell carcinoma. So squamous cell carcinoma, okay, the location, they are central. They are central. They are caused by smoking. They're central, they're caused by smoking. And there's only one paraneoplastic syndrome over here, the one paraneoplastic syndrome. This paraneoplastic syndrome is known as ectopic release of PTHRP, meaning ectopic parathyroid hormone related peptide secretion. So you have ectopic PTHRP, parathyroid hormone related peptide. So these patients can have signs symptoms of hypercalcemia. Am I correct? That is abdominal pain, bone pain, psychiatric disturbance, constipations. Am I correct? Yes or no? Can these patients have signs symptoms of hypercalcemia? Yes or no? Okay. So if they give you guys a question where they are trying to describe hypercalcemia, and they tell you what type of a cancer do you think this is, then can you guys remember that this is the squamous cell carcinoma? Okay. Okay. Next one is, what is the most important histological finding of squamous cell carcinoma? Let's see how many of us remembers what we find in squamous cell carcinoma on histology. This is a very easy, very high yield, very widely talked about, and I've talked about this a lot of times. What do we find in the histology of squamous cell carcinoma? Very good. Keratin pearls and what? Keratin pearls and IC bridges, meaning intercellular bridges. That's what we expect to find. So what we find is, we find keratin pearls, pearls of keratin, and intercellular bridges. That's what we expect to find on squamous cell carcinoma on histology. Okay. Let's look at the text. So to see if we have covered everything. First of all, they're central. They're hilar masses. They're present in the hilum like this. Okay, hilar masses, and they can cause cavitation. They're caused by cigarettes, and they can cause hypercalcemia. Signs and symptoms of which are abdominal pain, bone pain, psychiatric disturbance, and constipation. Then next one is keratin pearls. Keratin pearls meaning pearls of keratin like this, with intercellular bridges. This bridges over here, the intercellular bridges. That's that. These are known as squamous cell carcinoma on histology. Okay, next one is large cell carcinoma. Large cell carcinoma, they are not that high yield, but basically they are located on the peripheral one. They're highly anaplastic, meaning they're very undifferentiated and they have a poor prognosis, but they're also not very common. They're less responsive to chemotherapy, and they have to be removed surgically. The only question that you can receive from large cell carcinoma is based on the location. If they tell you that you have a tumor which is located on the peripheral, and on histology you have pleomorphic giant cells. Pleomorphic giant cells over here. Pleomorphic meaning that of variant morphology, and the cells are giants, and they're presented on the peripheral. So P for pleomorphic, P for peripheral. These two P's together, therefore large cell carcinoma. Okay, that's that. Not very common. You guys might not receive any questions from this one. Next one is carcinoid tumor or bronchial carcinoid tumor. That is basically, this could either be central or peripheral. This is not that high yield, but the thing is, they have a very good prognosis. The metastasis is very rare, and the symptoms are usually due to mass effect or carcinoid syndrome. The symptoms of carcinoid syndrome, what is the reason why? What is the neurotransmitter responsible behind carcinoid syndrome? What is the neurotransmitter responsible behind carcinoid syndrome? Basically, serotonin or 5-hydroxy indole acid. Okay, that's that. So you have flushing, diarrhea, and wheezing. If I tell you carcinoid syndrome, if I tell you that they are neuroendocrine tumors, what are the 3 stains that you expect to find which will be positive for carcinoid syndrome? Chromogranin, neuron-specific analase, and synaptophasin. Very good. Synaptophasin. So a patient with positive neuron-specific analase, chromogranin, synaptophasin, flushing, diarrhea, wheezing, can you easily diagnose that these patients are patients of carcinoid syndrome? Yes or no? Okay. Do these cancers secrete serotonin? Yes. Yes, they do. Okay. Are we clear about this? Okay. Can we move on to the next part? Before we move on to the next part, if I tell you that on histology of a cancer, of a lung cancer, on histology of a lung cancer, you expect to you find tall columnar cells which are secreting a lot of mucus. They're positive for mucin. What is the cancer? Very good. If I tell you that on histology you find keratin pearls and intercellular bridges, What is the diagnosis? Very good. If I tell you that on histology you find small oat cells, and which are neuroendocrine blue cells, blue neuroendocrine cells, these are known as small cells. Okay. These are known as, okay. Very good. Next one. Next one is if I tell you that if I tell you that you find a patient with flushing, wheezing, diarrhea, and then you find chromogranin, synaptophysin, neuron-specific ganglions, what is this carcinoma? Okay, very good. Are we confident about these lung cancers right now after reading with us, after reading the lecture? If you guys receive questions from these cancers in the USMLE exam, will you be confident? Okay. Okay. Are the pictures high yield? Yes, the pictures are high yield, but we have discussed the pictures now. Right now, we will discuss the picture. Okay. First of all, this is the Kulczycki cell, primitive blue cells, small cell lung carcinoma. Then you have all this mucus, easy to understand. There's mucus in the middle, right? This is adenocarcinoma. Then you have keratin pearls and intercellular bridges. This is small cell carcinoma, small cell adenocarcinoma. This is squamous cell carcinoma, adenocarcinoma. This is small cell lung carcinoma, and this is your large cell carcinoma, meaning pleomorphic giant cells. These giant cells over here. If you guys need, please write it down over here beneath the picture, so that next time when you read them, it will be easy for you, because it will already be identified. Okay, squamous cell, small cell lung carcinoma, squamous cell carcinoma. Okay, are we clear about this? What is your question, Dr. Mohammed? What is your question? Okay. Okay. Can we move on to the next part of the lecture? Okay. Okay, let's move on to the next part of the lecture. Okay, the next part of the lecture that we want to move on is basically, it's very easy to understand. That is lung abscess. Lung abscess. Lung abscess is basically, it's formed after there's lung infection. So there's a localized collection of pus within the parenchyma of the lungs, right? And this can be caused by either aspiration. For example, let's say that in a patient who is unconscious, okay, or alcoholic or epileptic patients, these patients are not sure that they don't remember if they have aspirated a foreign substance. So what happens is, if they aspirated a foreign substance, for example, food, this food comes and it goes to the lungs, it stays inside the lung for a long period of time, and then there's purulent pus formation because food contains microorganisms, and then this pus results in the formation of abscess. So the patients, who are the patients? The patients are usually unconscious patients, stroke patients, then epileptic patients, and alcoholic patients. Alcoholics. These are the 4 types of patients, and the questions will come accordingly. So this is high yield. Okay. How will you diagnose? Patients with lung abscess? If you do chest X-ray, you can find air fluid levels. Air fluid levels over here. You find this air fluid level. And the organisms are anaerobic, meaning that they are bacteroid, fusobacterium, and peptostreptococcus, these anaerobic organisms. Or staphylococcus is also common. That's that. Treatment is very easy. Treatment is incision and drainage, followed by antibiotics, just like any other abscess. That's that. Next one. Next one is, if I tell you that you have a lung abscess due to aspiration, in which part of the lungs are the abscess more common? Right part or left part? Right part. Upper lobe or lower lobe? Depends if the patient is standing or supine, right? Exactly. If the patient is standing, then which part? Lower lobe or upper lobe? Lower lobe. If the patient is supine, then If the patient is supine, then upper lobe. Okay, are we clear about this? Are we clear about this? Okay, next one. Okay, next one. Next one is if we have a patient with Pancoast tumor. If you have a patient with Pancoast tumor, once again, are apical tumors. They are known as superior sulcal tumors. They occur in the apex of the lungs, and the apex of the lungs have a lot of high yield structures that goes through. For example, the apex of the lungs, they have recurrent laryngeal nerve. We talked about this before. If there's compression, they can cause hoarseness. They have stellate ganglion, which is a cervical ganglion. If there's compression, they can cause Horner syndrome. Superior vena cava, if there's compression, this can cause superior vena cava syndrome. If there is a brachiocephalic vein compression, this can cause brachiocephalic syndromes. Then next one is brachial plexus, which can cause sensory motor defects, especially the nerve that is affected is ulnar nerve. Don't forget this, ulnar. You have a question in your USMLE where they tell you that you have a patient with back pain and peripheral numbness and of the lateral 4th and 5th digits. Which of the following is the most likely reason? The answer is Pancoast tumor, because due to ulnar nerve, because this is a more this is the most common nerve to get affected by Pancoast tumor. Next one is phrenic nerve, which can cause diaphragmatic paralysis. That's that. Okay, so these are the Pancoast tumors findings. Okay, do we need to discuss Pancoast tumor in details once again, because this is the second or third time we are discussing this? Do we need to discuss this in details? Because this is the second or third time we're discussing this. Okay, once again. Okay, Pancoast tumor. First of all, Pancoast tumor over here. Okay, Pancoast tumor. Pancoast tumor means apical tumor, apex of the lungs. If there's any tumor in the apex of the lungs, this is known as Pancoast tumor. Apex of the lungs have a lot of high yield structures. Number one structure is recurrent laryngeal nerve, which can cause hoarseness. Number two is another nerve, or known as stellate ganglion. This can cause Horner syndrome, ptosis, meiosis, and hydrosis. Next one is a vein. Two types of vein. First one is brachiocephalic vein, for which this can cause unilateral sign symptoms, for example, unilateral hand swelling. Another one is superior vena cava, which can cause facial plethora, superior vena cava, bilateral arm swellings, this and that. Two other nerves that goes through are, one is brachial plexus, for which patients can get sensory motor deficits. For example, the most common nerve to get affected is ulnar nerve. Another nerve that can get affected over here is phrenic nerve. So it depends on which structure is being compressed, and the clinical features will be there accordingly. Okay, are we clear about this? Okay. Okay. All right, next one. Next one is if we have a patient, okay, for example, let's say that this is, for example, let's say that this is the heart, right? This is the superior vena cava. This is the inferior vena cava. Now, you have obstruction of superior vena cava by a tumor. If there's obstruction of superior vena cava from the tumor, if you have a patient over here, okay, all these veins that are draining into the heart, the veins that is coming from the head, neck portion, the veins that are coming from the arms, okay, can they drain properly if you have a superior vena cava obstruction over here? Can they drain properly in the heart? Yes or no? No. If they do not drain, can these veins get engorged and swollen? And these parts, can they get swollen due to congestion? Yes or no? Okay. So you have bilateral arm congestion, and then you have facial plethora. Okay. And you can have edema. So basically what happens is an obstruction of the superior vena cava that impairs blood drainage from the head can cause facial plethora. And then they can also cause JVD, jugular venous distension, right? Because the jugular veins, they also drain over there. That's that. Upper extremities will have edema. And the most common cause is a malignancy or Pancoast tumor, or there can either be a thrombosis of the superior vein. This is a medical emergency, and the emergency is medical because the veins of the head, they're also draining in the superior vena cava. If you do not get rid of that obstruction, this can cause increased intracranial pressure and aneurysms. If there's a rupture of aneurysm, these patients can die of subarachnoid hemorrhages. Okay, easy to understand, very easy. If you have unilateral swelling, that is due to brachiocephalic obstruction. If it's a bilateral swelling, it's due to superior vena cava obstruction. Are we clear? Okay, are we clear about this? Yes, everything is bilateral in superior vena cava syndrome. Okay. Okay, Dr. Karbasi, would you unmute yourself and ask me the questions? I'll clear everything for you. Okay, first, Dr. Karbasi. Unmute yourself and ask me the questions. Oh, you can't. Okay. Okay, try unmuting now.
Yeah, no, it's possible. Sorry. Like, can you explain one more time the drawing because it was so fast? And then...
Okay, no problem. Look, what's going on over here is, okay, don't go away. Please stay with me, okay? What's going on over here is, if you, this is the heart, right? And this is the superior vena cava.
Yes.
I am discussing about two things, Pancoast tumor, superior vena cava. Are you clear about Pancoast tumor?
Yes, yes.
Okay, good, very good. Now I am talking about superior vena cava syndrome. Okay, superior vena cava, is this the vein that is responsible for draining all the vein of the upper extremity and head into the heart? Yes or no?
Yes, yes.
Okay. If you have a block, for example, by a tumor, or for example, if there is a thrombosis or any other reason, if there's a block of the superior vena cava, can the blood from the head and the arms,
No.
they drain into the heart? No.
No.
So the veins in the arm and head, can they not get engorged and build up with blood over here?
Yes.
Okay. So the patients of superior vena cava, their clinical features are facial swelling, arm swelling, bilateral arm swelling, facial swelling, and facial plethora. What happens is, if you do not get rid of this obstruction, this increased amount of pressure in the head, can this not cause venous distension of the head, or cause increased pressure in the intracranium, increasing the intracranial pressure? Yes or no?
Yes.
Okay.
Yes.
If there's high intracranial pressure, can this not be a cause of rupture aneurysms, formation
Yes.
of aneurysm and rupture? So this can increase the mortality of the patient. So this is why it's a medical emergency. That's why these patients have to get to the hospitals immediately in order to relieve the obstruction. Now, there's another condition in which this is known as brachiocephalic syndrome. Brachiocephalic syndrome is the same as superior vena cava syndrome, except that in superior vena cava, you have obstruction of the superior vena cava. That's why both arms are affected, right? In brachiocephalic, if there's a right brachiocephalic obstruction, then the right arm will be swollen. If it's a left brachiocephalic obstruction, then there will be a left arm swelling. So in brachiocephalic, it's unilateral. That's what I said. Are you clear now?
I got it. Yeah. And Pancoast tumors, like the picture which you also explained us that in the apex, is there like a tumor, then it can affect the phrenic nerve, the superior vena cava, the bronchocephalic veins. Okay.
Right.
Yeah. Perfect.
Okay. Perfect. Okay.
Perfect.
Next one is Dr. Mohammed. Medical emergency. Repeat, please. Medical emergency is basically what I
It's
just.
okay, doctor.
Okay. Perfect. Okay.
You already repeated.
Okay. So hope that answers everyone's question. Any other question from any other students before we finish respiratory pathology? Any other question? Any other question? Did you guys understand the respiratory pathology? Okay, perfect. Okay. Do you guys want to do the respiratory pharma today? It's not that hard. It's very easy. Respiratory pharma is only 2 pages. Okay, respiratory pharma is only 2 pages. Okay. Okay, tomorrow, please. Okay, fine. So we'll do it tomorrow. Okay, no problem. Since most of you guys want to do it tomorrow, we will do it tomorrow. But basically, I wanted to start genetics tomorrow. So what I will do is either we will do respiratory pharma tomorrow, or I will make a separate lecture of respiratory pharma and I will post it on the group. Okay. Okay. You guys think that's a good option? No? Okay. Okay, how about this? How about instead of doing UWorld questions, we finish the respiratory system? Okay. Okay. So what we can do is let's take a break for 10 minutes and come back so that we can all feel fresh. Okay, perfect. Okay, let's take a break for 10 minutes and let's come back and finish respiratory pharma so that we can start fresh with the basic sciences tomorrow. Okay. I'll see you guys in 10 minutes. Okay. Okay. Is everyone back from their break? Is everyone back from their break? Okay. Are we ready to begin the respiratory pharmacology? Okay, I know we are a little bit tired, but this is good for us. I'm going to tell you why. Because after today, most of us will be done with our organ systems. Okay. Do we have the first batch of students who started from us from the very beginning? And for them, today is the last day for the finishing of organ systems, because I really want to congratulate you guys. Let's see who you guys are. The first batch, Dr. Karbasi, Dr. Hossam, who else? From the first batch of students. Who else is here? Dr. Lala. Very good. Who else? I know a lot of you guys are listening to this lecture on a recording. So I know you guys are there too. Over here, we have Dr. Adhanom, Dr. Uday. Who else? Who else has been with us for the last 50 lectures? For finishing, Dr. Dahlia has missed cardio and endo, but overall, she has been with us for the entire organ systems, more or less. Dr. Nikki, very good. Okay. First of all, let me thank you. Thank you so much for staying with us, for putting your time and trust in our lectures. Thank you for letting us help you in order to do well in the exam. And also, thank you for helping us out in carrying out our lectures. Because if you guys weren't here, then these lectures would not have happened. So the first batch of students for the Zoom lectures, I really want to thank you guys, because you guys are the ones through which we started the lectures with. Okay, so thank you so much. And so with that being said, let's finish what we started. And from tomorrow, we can jump into the basic sciences. And in no time, you guys will be done with your USMLE step 1. Okay. Okay. Thank you so much. Okay, perfect. So let's begin with the respiratory system. First of all, can you guys, okay, let me share the screen. Okay, can you guys see my screen over here? Okay, okay, okay. So let's begin with the respiratory pharma. Okay, let's begin with the respiratory pharmacology over here. Okay, okay. Okay, so let's begin with this respiratory pharmacology. It's very easy. At the same time, it's also very high yield, in the sense that we will receive a lot of questions from over here, but it's really, really easy, because most of the drugs are used by us on a regular basis, and we are very, very, very well acquainted with these drugs. Okay, first of all, our H1 blockers. Very easy to understand that histamine blockers are antihistamines. Okay, antihistamines. H1 blockers. We have 2 generations of H1 blockers. First of all, we have the first generation, then we have the second generation. The difference between first and second generations are basically on a simple thing, that is sedative, meaning that the first generations they will cause increase sedation. The second generations have less or to no sedative effects. The first generations, they are they will end in the first generations of antihistamines, they will end in ENE, INE, or EN, or ATE. Very easy to understand, meaning that the first generation of H1 blockers, H1 first generation, these are diphenhydramine. Okay, I'm not going to diphen, okay? Forgive me if I may make a mistake with the spelling. Diphenhydramine, INE, then dimenhydrinate, then chlorpheniramine, okay, chlorpheniramine or chlorpheniramine, whatever, whichever you guys prefer to pronounce, that INE. So INE and ATEs, basically that's that. That's the first generation. Second generation, they will end in ADI, and the names, meaning fexofenadine, fexo, very famous drug, fexofenadine, loratadine, then desloratadine. They will both block the H1 blockers, the histamine blockers. What is the use of blocking histamine blockers? If we block histamine, then can we prevent mast cell destabilizations, and prevent attack of mast cells and prevent bronchoconstriction? Yes or no? Antihistamines, yes. So if we do that, then can we use them for allergic type of bronchial asthma? Allergic bronchial asthma. Yes, so that's what they're used for. They're used for allergy. They're used for allergic bronchial asthma. And the first generation of antihistamine, they're also used for inducing sleep. So they're also used for sleep aid. Okay, and the first generation of antihistamines, they're also anti-muscarinic. For this anti-muscarinic effect, or I mean this anti-muscarinic effect, can we use these drugs for motion sickness? How we use scopolamine and hyoscine for like how we use them for motion sickness. Can we also use them for motion sickness? Yes. So sometimes they're also used for motion sickness. Anti-muscarinic effect. Okay, next one is second generation. Second generations, they are also used. They are used only for allergic bronchial asthma or allergy, and nothing else. Since they do not cause sedation, they are not used for sedation. They do not have anti-muscarinic effects. That's why they are not used for motion sickness, and that's that. And the first generation, they also have some degree of alpha 1 antagonistic activity, anti-alpha 1 activity. Okay, so that is all your knowledge about histamines. So first generations are diphenhydramine, dimenhydrinate, chlorpheniramine, brompheniramine, doxylamine. They're used for allergy, motion sickness, and sleep aid. Second generation is loratadine, fexofenadine, dexloratadine. They're used for allergy, and they have less sedative because they have decreased entrance into the central nervous system. They have more entrance, they have less entrance. Okay, are we clear about antihistamines? Okay, next one is guaifenesin. Guaifenesin. Okay, I apologize for mentioning guaifenesin. Okay, it's guaifenesin. Guaifenesin is basically an expectorant. What is an expectorant? Meaning that you have mucosal secretion of the coughs. If they are thick, for example, in cystic fibrosis, they get very thick. So we can use guaifenesin in cystic fibrosis, which will thin down the mucus, thin down the respiratory secretion, and it will cause easily the mucus can then leave. The way that they break down the mucus secretion is that they affect the N terminal and the S terminal ends of the mucus. Basically, the mucuses, they have proteins which are held together by bonds, and expectorants, they go and they break down the bonds in between the proteins. So that's that, and they try to make it very thin so that they can be easily let out. So they are used in cystic fibrosis or primary ciliary dyskinesia or any reason where the mucus is very tough. This is high yield guaifenesin. Okay, guaifenesin. Okay, are we clear about guaifenesin? Easy to understand, am I correct? Okay, next one is also an expectorant because it's a mucolytic, N-acetylcysteine. They will also disrupt the disulfide bonds in between the mucus, and this will liquefy the mucus in cystic fibrosis and COPD. And they are mucolytic. They will also thin down and break down the mucus, and they are used for getting the mucus out. For example, in thick mucus formation, once again in COPD, cystic fibrosis, primary ciliary dyskinesia, we can use N-acetylcysteine. N-acetylcysteine will break down disulfide bonds. Okay, are we clear about this N-acetylcysteine? Not worry, we will do a revision very quick. Just try to remember this. Okay, yes or no? N-acetylcysteine. Yes or no? Okay. easy to understand. Next one is dextromethorphan. Dextromethorphan. Have you guys ever heard of cough syrup abuse? Cough syrup, how a lot of it's a very easy access to codeine, meaning that this dextromethorphans, they have codeines. Codeines are a type of opioids, right? So they're antitussive, meaning that they prevent cough, right? How? They will antagonize NMDA, the glutamate receptors. Glutamate receptors are excitatory receptors. Excitatory receptors, when they are stimulated, can cause cough. If you antagonize the excitation, there will be no excitation, and this will prevent cough. This has mild opioid effect when used in access. As a result, they're used for abuse. They're used for abuse. And the opioids, since it's an opioid, if it's an overdose, then we can give naloxone, okay? And since it's an NMDA antagonist, there's a high chance that there could be serotonergic effect. So if it's used with SSRI, that's dextromethorphan, or SNRI, or TCA, then they can cause serotonin syndrome. Okay. Are we clear about this? Yes? Okay. Which group of drug has anti-muscarinic effect? First generation antihistamine or second generation antihistamine? First generation. Which drug is used only for allergy and nothing else? And bronchial asthma. Okay. Which can cause which drugs can cause anti-muscarinic effect? As a result, they can be used in motion sickness. Okay. Next one is, which drug has anti-NMDA effect for which there could be abuse potential? Very good. Which drug is used as a mucolytic? And acetylcysteine. Very good. Which drug is used as thinning of mucus? Mucus thinning. Guaifenesin, and also an acetylcysteine, more or less. Okay. Okay, next one is alpha adrenergic agents. If we use alpha adrenergic agents, will it cause vasoconstriction or vasodilatation? Vasoconstriction. So if we have, for example, nasal obstruction due to congestion, right? Do you remember how when the last time you had a common cold and you had bilateral nasal obstructions, it was filled up with mucus and you were draining your mucus and you couldn't breathe, right? Yes or no? Do you guys remember that feeling where your nasals are all blocked up by mucus? Yes. If you give a vasoconstrictor, for example, pseudoephedrine or phenylephrine drops, and it causes vasoconstriction, can all those excess mucus get absorbed away in your vessels? Yes or no? Yes. So we can use pseudoephedrines or phenylephrines, which are alpha agonists. They will reduce hyperemia, edema, and this will decrease the nasal congestion, and this will open up the ET tubes, eustachian tubes. The problem is that they cause hypertension because they are agonists, so they can cause vasoconstriction, which can increase the afterload, and hypertension can be happening over here. And also there's another thing that these ones, they cause is rebound congestion, meaning that if it's vasoconstricted due to alpha agonist for a long period of time, this can result in vasodilatation and the patients can have worsening of the congestion. So rebound congestion can happen. That is also another side effect. Okay. And another one is nasal mucosal atrophy. Please write it down in the adverse effect. They cause nasal mucosal atrophy, for which there could be bleeding. Epistaxis, nasal mucosal atrophy, nasal mucosal atrophy. Okay. Are we clear about this? Okay. Are we clear about this? Yes or no? Okay. Next one is pulmonary hypertension drugs. Drugs used in pulmonary hypertension. Endothelin, is it a vasoconstrictor or not a vasoconstrictor? Vasoconstrictor. If we block endothelin, can this promote vasodilatation? Okay. If we use endothelin antagonist, can this decrease pulmonary vascular resistance? Are you certain about this? Are you certain? Okay. Bosentan. Okay. Bosentan. Certainly. Bosentan. Certainly. I don't know why this helps me remember Bosentan. Bosentan certainly decreases pulmonary vascular resistance. Bosentan certainly decreases pulmonary vascular resistance. This is a very high yield drug. Okay, this can also cause hepatotoxicity, so we have to monitor the liver function test. And this is also high yield because it's metabolized in the liver. So the metabolic products can accumulate in the liver and cause hepatotoxicity. So bosentan. Okay, are we clear about this? Bosentan. Okay, is my voice breaking or is the voice okay? Is the voice okay? Okay. Another one is phosphodiesterase 5 inhibitors. Phosphodiesterase 5, which group of messenger system is responsible for being broken down by phosphodiesterase? CMP and CGMP, am I correct? CGMP, okay. If we prevent the breakdown of CGMP, this increased CGMP, can it cause vasodilatation? Yes. So phosphodiesterase 5 inhibitors, do you guys remember we talked about one phosphodiesterase 5 inhibitors which can be used to treat erectile dysfunction? Well, what was the name of that drug? Sildenafil. Very good. So PDE5 inhibitors, for example, sildenafil, they can be used to prevent phosphodiesterase 5, which will result in increased CGMP and increase in nitric oxide. That's that. And can we use nitrates with sildenafil? Can we use nitrates with sildenafil? No, because this will cause shock and hypotension. Extreme vasodilatation, shock and hypotension. Okay, next one. Next one is prostacyclin analogs. Prostacyclin. Can prostacyclins be vasodilators? Vasodilators? Yes or no? Okay. So if we use an analog, for example, epoprostenol or iloprost, okay, both of them have the word prost in it, okay, they can cause vasodilatation and prevent platelet aggregation. If there's inhibition of platelet aggregation, there's a less chance for formation of thrombus, right? So that's also another reason. Both of them can decrease PVR. Okay. Are we clear about this? Yes or no? Okay. Okay. Okay, next one. Next one is asthma drugs. Okay, so we will talk about asthma drugs. First of all, we'll talk about them in a blank page, and then we will discuss this from first aid. First of all, asthma. First of all, please put your attention to this. This is very high yield and really easy. First of all, if you have a patient who has asthma, if they are exposed to allergens, okay, if they're exposed to allergens, the next step of asthma is there is antigen and IgE on mast cells, right? IgE and antigen on mast cells, what do? They cause breakdown of the mast cells and they cause the release of mediators. What are the mediators that are released? Mediators are basically leukotrienes, histamines, right? So those mediators are released. These mediators, they do two types of function. First of all, these mediators, they have an early response and they have a late response. Immediately in an early response, what do? They cause bronchoconstriction. And in a late response, they cause bronchial hyperreactivity, meaning that they make the bronchial hyperreactive. So next time a foreign substance comes, they constrict immediately. Okay, the drugs that can be used in each and every steps are very easy. First of all, exposure to allergens. What can we do to prevent exposure to allergens? Avoid allergens, meaning cover your mouth, do not get out during winter, keep your house clean, stay away from cats and dogs. Okay, then wear a mask. Those are the ones. That is what you can do. Avoidance is number one to prevent bronchial asthma. Next one, if there is exposure to allergens, the next step is you want to prevent this mast cell destabilization. So you want to use a mast cell stabilizer. The mast cell stabilizer is called Umle Zumab. Zumab, basically meaning, oh, mast cell, please do not destabilize. Okay. Oh, mast cell, please do not destabilize for Umle Zumab. Easiest way you can remember this. Okay. If there is mast cell destabilization and there's release of the mediators, the next thing you want to do is you want to prevent the release of histamines, leukotrienes, and all these mediators. So the number one anti-inflammatory drug that you can use to prevent the formation of these mediators is prevention of the breakdown of the arachidonic acid metabolites. So you can use steroids. And the father and mother of, the parents of all anti-inflammatory substances, that is steroids. It will stop down everything. Steroids will prevent the breakdown of arachidonic acids, and they will prevent the release of leukotrienes, histamines, right? That's that. Next one. Another one is leukotriene inhibitors. Leukotriene inhibitors are known as anti-leukotrienes. Anti-leukotrienes were known as Monteleucast and Zafir Lucas. Anti-leukotrienes. Okay, anti-leukotrienes are known as that. Next one is you can also use another one. First of all, omalizumab is for mast cell stabilization and anti-IgE antibody. Since it's an anti-IgE antibody, this will prevent mast cell stabilization. Another one we can use is nedochromyl sodium or sodium chromogyllin. That is a mast cell stabilizer. Okay. Then what else? What else can we use? We can also use we can also use the most common drugs, right? Almost forgot about them. That is beta-2 agonist, salbutamol. That will cause vasodilatation, and that will cause bronchodilation. Or we can also use muscarinic antagonist that can also cause bronchodilation. That is theophylline. The name of the drug is Docopa, right? What was the name of anti-muscarinic? The names of the Docopa or ipratropium, tiotropium, right? Those are the drugs. My apologies, I kind of forgot the names of ipratropium, tiotropium. Okay, that's that. Another one that we can use for bronchodilation are methylxanthines. Methylxanthines are aminophylline, theophylline, right? Aminophylline, theophyllines. That's that. Okay. Have you guys understood this small breakdown of the anti-asthmatic drugs? Anti-asthmatic drugs. Okay, don't worry. I know it's a bit confusing, but we will solidify this information right now. Okay, we will solidify this information right now. Don't worry about this. Okay, let's go back to our text. Let's go back to our test. First of all, asthma drugs. Asthma drugs, first of all, their bronchoconstriction is number one. And bronchoconstriction occurs by inflammation or parasympathetic tone. So this is the mode of action of the drug. Either you have to use anti-inflammatories or anti-parasympathetic. So that's that. Number one is beta-2 agonist. Very easy to understand that we have albuterol, which are short-acting. This will prevent bronchoconstriction and they will relax the bronchial smooth muscle. And they're used for acute asthmatic attacks. For acute attacks, we can use them. But the thing is, beta agonists can cause arrhythmia. They can cause tachycardia. This is high yield because they will also work on other beta 2s, so they can cause tachycardia and arrhythmia. Next one is salmeterol and formoterol. These are long-acting beta 2 agonists. These are long-acting and they are used for prophylaxis, meaning you want to prevent them. For example, you know you are going somewhere where you will be exposed to allergens and you want to prevent this, so you want to use salmeterol and formoterol. That's that. Next one is inhaled corticosteroids. So we can use inhaled corticosteroids, which will prevent your which will prevent the formation of the mediators, right? These are fluticasone and budesonide. They will inhibit the synthesis of all cytokines. And steroids, we have talked about their mechanism before, that they will prevent the activation of nuclear factor of kappa ligand. And this is the transcription factor that induces the formation of TNF and other inflammatory agents. And that's why you will have decreased formation of all types of inflammatory substances. The thing is, after using corticosteroids, you always have to rinse your mouth with mouthwash, right? Because steroids can also damage your mouth flora, and this can result in formation of fungus or oral thrush. This is also high yield. Remembering to wash your mouth with an mouth rinser to prevent the formation of oral thrush. Did we understand the first two drugs? Did we understand the first two drugs? Okay. Next one is muscarinic antagonist, ipratropium and tiotropium. These will competitively block the muscarinic receptors and they will prevent bronchoconstriction. Muscarinic receptors are parasympathetic receptors. So if you block parasympathetic, obviously there will be sympathetic. So they're used to block muscarinic receptors and they are used for COPD. And tiotropium is long acting. So this is easy to understand. Muscarinic are anti-parasympathetics. That's that. Next one is anti-leukotrienes. We talked about this. That is zafirleucos and monteleucos. They will, if there is formation of the leukotrienes, they will block the leukotrienes, that is cis-LT1, and they are very good for aspirin and exercise-induced asthma. Okay. Another one is there is a leukotriene pathway and a lipoxygenase pathway, and xaluton is a lipoxygenase inhibitor. Xaluton is a lipoxygenase inhibitor. They will block the conversion of arachidonic acid to leukotrienes. They are hepatotoxic. Okay, that's that. Anti-leukotrienes, are we clear about them? Anti-leukotrienes. Okay. Next one is methylxanthines. Methylxanthines are the drugs that can cause increase of cyclic AMP. Cyclic AMP, for example, theophylline, they cause increase in cyclic AMP because they prevent the breakdown of cyclic AMP, right? And cyclic AMP, if you increase cyclic AMP, can there be increased bronchodilation? Yes or no? Yes or no? If there's increased cyclic AMP and it causes increased bronchodilation? Yes. If there's increased bronchodilation, this will prevent the asthmatic attacks. So they will prevent bronchodilation and they're metabolized by cytochrome P50, P450. That's that. Another one we missed out was anti-IgE antibody, that is omalizumab. They will bind to the serum IgE and block the action of IgE. If they block the action of IgE, mast cell destabilization will not occur. All mast cells do not destabilize. It's for omalizumab. Do not forget this. These are anti-IgE antibodies. Next one is Crohn's, right? Crohn's for cromolyn. That is the mast cell stabilizer. Cromolyn sodium. They're not used on a regular basis. That's that. Okay. And another one is IL-5. IL-5 is required because IL-5, they can cause eosinophils to differentiate and mature. And we know that eosinophils are responsible for causing an allergic response. So if you want to prevent IL-5, then you can use two other new drugs. These are comparatively new. These were not there in 2019. That is mepolizumab and benralizumab. Not high yield, to be honest. If you want to make sure that you want to answer those extra hard questions, then that's that. Mepolizumab and benralizumab. Okay. Unfortunately, we could not come up with any mnemonics for this one. So that's that. Even if you cannot remember this is still okay. Okay, that's that. Okay. Can I give you guys can I give you guys 1 minute to look at the drugs? All you need to know is the mechanism of action. I'm pretty sure even without giving you guys the time, you guys can tell me the names. First of all, albuterol and salmeterol. What type of drugs are them? Albuterols and salmeterol. What type of drugs are these drugs? Very good. Fluticasone and budesonide. What type of drugs are them? What type of drugs are budesonide and fluticasone? Very good, steroids, okay. Ipratropium and tiotropium, what type of drugs are they? Very good. Zafirleucist, monteleucist, what type of drugs are they? Anti-leukotrienes, very good. Omalizumab, what type of drugs are they? Okay, next one is caffeine, theophyllenes, aminophyllenes. What type of drugs are they? Very good, methylxanthines. Okay, netochromyl sodium or sodium cromolyn. What type of drugs are they? Mast cell stabilizer. Very good. Okay, and the new drugs, benralizumab and mepolizumab. What type of drugs are they? Okay. Are we clear about respiratory pharma? These are the new drugs, mepolizumab and benralizumab over here. Let me write the name down. Okay. Mepolizumab, then benralizumab, and there's another one that is reslizumab. Resli. Okay. Are we clear about this? Okay. With that being said, my friends, we are done with the organ systems. Okay, we are done with the organ systems. Are we clear? Okay, how do you guys feel? Do you guys feel good? Confident? Happy? Okay. Okay, very good. Okay, congratulations and thank you so much. For the new students, if you guys want, you guys can contact us if you want to receive the previous lectures of our organ systems, or if you want to wait for that for those systems to come again, then you guys can wait accordingly, and you have nothing to worry about, because from tomorrow we will start the basic sciences and then we will finish the organ systems again. Okay, so from tomorrow 9 a.m. we will start with the basic sciences. Okay, So with that being said, I'm not going to keep you guys waiting for any long. It has been a long lecture. We have finished everything of the respiratory system, and you guys can happily go and relax, chill, do a couple of questions, and get ready for tomorrow. Okay. If you guys have any questions, please let us know via email. And I hope you guys have a great day today. And I'll see you guys tomorrow at 9 a.m. Okay. Bye-bye now.